Good evening and welcome to the fifth Eizoc Midcon conference, which is being held on the virtual platform on this beautiful evening of the 31st of July 2021. This is a historic day for all of us. We have three coordinators to conduct and take the program further. I request Dr. Devashish Das and Dr. Satyajit Sinha, the two coordinators, to be ready, and I hand over the first part for coordination to Dr. Satyajit Sinha. Dr. Satyajit, please take care of the inaugural part.
Dr. Satyajit is not online. May I invite our Honorable President, Dr. Abhijit Ghosh, to deliver his welcome address. Mr. President, sir.
Thank you, Devashish. Thank you all. Thank you. Good evening to you. All the best. Welcome to this fifth Eizoc Midcon conference on a virtual basis. As you know, virtual programs have become a reality these days, possibly due to the scenario. We do not know when we'll be going back to the physical one, but as you know, with everything, you have a good and a bad thing. In a physical, we could see ourselves only about twice a year, but with this virtual conference, we are seeing you weekly, I suppose, at least twice a month, much more than we have seen you physically. So that is a very optimistic thing which I thought I should share with you. It is very important that we are seeing with each other much more common. I have a word for Dr. Steve, but I will speak when he comes. Give me a minute then. I have seen the Herculean work which has been done by your secretary, chairman, scientific committee, and everyone to make this conference such a success. I have all the best regards for you people. Carry on the good work which you are doing. Let us have a wonderful evening together. Thank you.
Thank you, Mr. President, sir. We should say you are an inspiration for all of us as the president. With that, may I invite our Honorable Secretary, Dr. Pranav Ranjan, to deliver his report. Dr. Pranav, sir.
Thank you, Dr. Devashish. It's a proud and a privileged moment for me to give a welcome address on the fifth Midcon, which is being held today. And I'll just take you briefly to the history of Eizoc. Eizoc started its golden journey in the 70s of last century. Objective was to bring ophthalmologists of the East on a common platform. Dr. L.C. Datta, Dr. A.N. Pandya, Dr. U.C. Behera, Dr. M. Lala Singh, Dr. K.R. Datta were the architects of the movement. Professor Ranbir Mukherjee took the lead in formation of society and constitution. The first Eizoc conference was held in Calcutta in 1985 under the leadership of Professor Dr. Sri Mohan Mishra from Bihar. Eizoc constitution drafted by Professor Ranbir Mukherjee was adopted in the general body meeting. Professor Dr. Sri Mohan Mishra became the first president of Eizoc. Office of Eizoc was in Calcutta with Dr. Ramendra Lal Saha as the secretary and Dr. Chandi Das Datta as the treasurer. Thereafter, annual conferences started being held in different states of the East. Media conference Midcon saw the light of the day by the visionary effort of Dr. B.N. Gupta's in 2016. I'll just take you through the memory lane with few photographs. This is the photograph of the first Midcon, which was held in Shillong in April 2016. We can see Dr. B.N. Gupta, Dr. S.C. Das, and Dr. Devashish Bhattacharya and Dr. Jennifer. This is the picture of the second Midcon, which was held in Imphal in 2017, April. This is the picture of the third, which was held in Gangtok. And we can see Dr. B.N. Gupta, the secretary, and Dr. Arvind Jaiswal, the then president of Eizoc, on the stage lighting the lamp for the inaugural function. And this is the last one before COVID set in, the 2019 April in Agartala. And we had a galaxy and a huge gathering to grace the occasion. COVID taught us the art of holding webinars, and we have been holding webinars very regularly. And I think Dr. Devashish will brief you all about that. And the best part is that during webinars, society started the noble tradition of honoring senior members from each state. We have honored Dr. B.K. Sahai from Jharkhand, Dr. S.C. Das from Odisha, Dr. P.L. Saha from West Bengal, and Dr. M. Satyabhama Devi from the Northeast for their exemplary contribution to Eizoc. Important landmarks during COVID times, because we could not meet physically. Few of the things which happened is that Dr. B.N. Gupta became the vice president. Pandemic forced us to cancel 2020 MidCon and the annual conference. The executive committee decided to have an abridged virtual MidCon in 2021, which we are witnessing today. Reports were submitted by various committees formed in 2019 and 20, and they are at different stages of implementation, like the Skill Transfer Committee, the Award Committee, the Constitution Review Committee, and the Coordination Committee. Thank you, Honorable President, sir, Dr. Avijit Ghosh, all office bearers, and members of the society for their continuous support. One is never too old to set another goal or to dream a new dream. So one is always, and one should always have a dream and have a new dream. Thank you so much. Thank you, Devashish, for giving me the opportunity. And since Dr. Satyajit is not there, I would request the Chairman Scientific Committee, Dr. Devashish Das, to give his presentation. Let me stop share my screen. Okay.
So we have Dr. Nagendra's report as treasurer before me. Shall I proceed, or shall Dr. Nagendra take care?
Dr.
Actually,
Nagendra, if you are prepared, please, you can proceed with your presentation. After that, Devashish will follow you.
Dr. Nagendra, will you proceed, or shall I proceed?
As per your wish, sir.
Devashish, you proceed. After that, Nagendra will follow you.
Absolutely. So with that, I think I'll submit the opportunities we had created for our next generation. We planned the Voice of the East as we represent the Eastern Indian part of it, the fortnightly evening online programs on every Wednesday evenings. There were two alternative academic programs was done, followed by one secretarial program. And in these programs, the responsibility of the academic program was given to one state at a time, flowing down in the alphabetical order. The state in charge of the academic programs had put their main thrust on the younger generations than on the established speakers and academicians. The state organized the academic program, kept half of their speakers from their state and the remaining half from the other respective states. And this is how we planned the entire thing. We had didactic lectures, we had debates, and today in the midterm conference, we will be having our quiz contests. We had NLP programs, mind-boosting workshops by Mr. Sudeep Sinha. And these are the program outlines we did over the last 1 year. 7th October, it was cataract. On 21st October, retina. 4th November, investments and emergencies. 18th November, cornea. 2nd December, SICS. 3rd February, the annual meet. 3rd March, the flax. And 7th April, the toric IOLs. Apart from these programs, we also did three programs on COVID and the COVID infections and the COVID management for our members. And this has been distributed over the last 1 year. The new tradition we did is felicitating the senior members of the host state during our webinars. Initially, we felicitated the advisors of the respective states, and this will then be followed by the other senior members. The last Voice of the East, we felicitated Dr. M. Satyabhama Devi. So these are the felicitations we had done earlier. With that, I conclude my report, and I request Dr. Nagendra Prasad to proceed with his presentation.
Thank you, Devashish sir. I am just going to share the screen. I want to share. Okay. I'm going to read out my proceedings. Okay, sir. I could not share the screen because it is not up to date.
Please go ahead. Please go ahead.
Go ahead, go ahead.
At the outset, I congratulate Dr. Pranav sir, Devashish sir, and above all, Dr. Abhijit Ghosh sir for their continuous effort and commitment towards the Eastern India General Ophthalmic Congress and having this conference MidCon this time. It's my proud privilege to present audited account of Eizoc of the last and present financial year, that is the financial years of 19 and 2029 and 20 and 20 and 21, because we are presenting both the combined. Last year could not present due to the pandemics, and there is a shift of the bank to the merger of bank to the Punjab National Bank, so we could not get the details of the financial transactions. First, I'm going to read out the 1920 report. That is, we have a total income of 3,54,094 rupees and 34 paisas, and the total expenditure was 1,75,730. The excess of income over expenditure was 1,05,479 and 84 paisa, and cash at the bank at bank is 17 lakh for 41,549 and 50. And
ब्लॉक किया हुआ है। अरे
can you,
ब्लॉक किया हुआ है।
yeah, and we have a fixed deposit of 1,90,000 with the interest of the last year 1920 74,034 paisa. This includes 1,97,400 rupees, and the total deposit we have as an asset is including the fixed deposit and fixed deposit in the total cash in the bank is 19 lakhs 39,192 and 94. Now coming to the reports of 2021, 20 and 21, this time we have very less income. The total income was 27,278, and the total expenditure was 1,72,869. Excess of expenditure over income is 1,45,591. Here we are lacking, and we have more expenditure than the income. Cash at bank is 18 lakhs 12,184, including the fixed deposit and the interest incurred upon it. Due to pandemic, as you know, the society is running low in the income. Our main source of income is life membership, donation from the company, delegate fee by hosting the annual conference states, and due to virtual platform, we are unable to part delegate fee and the donation, so we are running low in income. In the wake of this, I would like to suggest, as suggested by Secretary Dr. Pranav, to hold a sponsored webinar, and the money saved will be added to the Eizoc account. As our money is in the current account without interest, hence I suggest to fix deposit all the money except 5 lakhs from current account to the to face the interest. Last executive, yesterday the executive Dr. Ravi, President sir has already given permission to fix deposit at least 14 lakhs as per to the fixed account, so we can have interest upon it. And I want to liquidate the fixed deposit because they are not bringing any interest. So we have to liquidate, and I have to refix it for the benefit of the society. And this and I want to say that we can always have webinars which will be sponsored by the company people, and the money saved from that will be added to the account. This is my proposal and for the GBM. Thank you, sir. Thanks for your patience here.
Thank you so much, Dr. Nagendra Prasad. With that, we come over to our editor of the journal, Dr. Sujoy Samanta. May I request Dr. Sujoy Samanta to initiate the e-journal he has worked upon over the last few months. Dr.
1
Sujay,
minute, Devashish. Can I welcome Dr. Steve, please?
please.
It's nice to
Welcome.
see you. It's
Please,
nice
sir.
to see
Please,
you.
sir. Please, sir. Please, sir. Please.
Thank you very much. It's nice to see all of you. It's a pleasure to be
Welcome,
here.
welcome, Dr. Steve.
Welcome,
Thank
Dr.
you.
Welcome, sir.
Welcome.
Thank you very much.
And we also
Welcome,
have
sir.
welcome Dr. R.C. Meher, our incoming president, sir. Thank you so much. So nice to see you, Meher sir. Carry on.
With that, let us proceed with Dr. Sujay Samanta. Sujay.
Thank you, Dr. Devashish. Good evening, everyone. President, sir, our guest faculty, Dr. Steve, our esteemed members present. Now I would like to release our e-journal.
Thank you very much. It's nice to see all of you.
Welcome, welcome.
E-journal.
Sujay, you can close the window and open it again.
Okay. Is this start by? This one. Which one? Yeah. Sorry. So it's because it's an e-journal.
Can you go to the full view? Otherwise, continue also.
Is it clear?
Yeah, it's clear. Yeah, go ahead.
Because it's e-journal, we have named it Smart Eye, and we have 5 articles in this issue, which we are releasing on the occasion of our MidCon. The first article is by Dr. Swati Agarwal et al., Dr. Ajay Pal, and Dr. Sagar Bhargav. It's a comparison of clinical outcome between image-guided system versus smartphone marker app for toric IL implant. The second is a text review by Dr. Vibhuti Kashyap. It is on pattern ERG, and these are the main. The third is a clinical study, clinical social study of low vision aid on the patients from Patna by Dr. Aswini Kumar. And he has, this is an original article he has done in over 50 patients. And then coming to the fourth article is by Dr. Mamta Sinha and Dr. Vibhuti Sinha, is on allergic conjunctivitis. It's a practice pattern survey from some 150 patients from Patna in Bihar. And the last article is by Dr. L.K. Agarwal from Patna. It's viral conjunctivitis, the treatment rationale. Thank you.
Thank you so much, Dr. Sujay Samanta. May I request you to put this e-journal in all the Eizoc groups available, such that it is available to the readers from today onwards.
Sure, I will do that. Thank you.
Thank you. With that, may I request Dr. J.G. Agarwal to present to us about the website eizoc.in.
Thank you, Devashish. Thank you, Devashish.
In the meanwhile, I'll suggest that the e-journal on record will be recorded as having been released by all the office bearers and Dr. Steve Ashnoff. Yeah, go ahead, Dr. Agarwal.
Yes, sir. Just I want to share my screen. Can you see it?
No.
Hello? Hello? Hello?
We can't see. We can't see.
It is not shared, Dr. Agarwal.
Okay.
You have not shared the screen.
Yes, I am sharing this.
Yeah, it
Yes.
is now coming.
Now
Please
it's
go ahead.
coming.
Please
Okay.
go ahead.
Okay.
But it is not full screen, you know.
Oh.
Now it is better. Yeah, please
Yeah.
go ahead.
Yes, thank you, President Sir, and our secretary and my dynamic chairman scientific committee. With this, for your all efforts, this mid-con session has came to the light. Now, I want to highlight my website because I am associated with this website for last 2 years, and this is the home page, and you can just enjoy it. By in this we can have the just glimpse of news and announcement and with recent events, and this is the presidential page, and here you can see our president with all his introductions and his achievements. Now, this is our incoming president's Dr. R.C. Meher sir, and this is the vice president page, and here you can see Dr. B.N. Gupta along with his all achievements. This is the secretary's desk. It is Dr. Pranav Ranjan's, and he has narrated very beautifully with his aims and objectives. And with from this, we have the administrative tools like already manager and notice board manager. And usually I get control over the website by this. Now, this is the executive members. It is just updated, and it is the executive members of 2021. Here you can see the photographs along with names and phone numbers. You can get contact with it. And this is also the different states members. There's a members managing committee are all here from the other states, Jharkhand, Odisha, West Bengal, Arunachal Pradesh, and Meghalaya. These are advisory board members. Here you can see our senior most ASB Sahai, Dr. H.K. Chaudhary, Dr. C.S. Das, Dr. B.K. Sahai, and Dr. Devashish Bhattacharya. Now it is a notice board. As you see, it is if you go through the notice board, you will see the upcoming events and all things that you need to know for these events. This is a very beautiful gallery, and you can just enjoy the previous and pictures of past conferences. This is award and oration page. You can go through all in every year's awardees with their names. Now, that is all about. You can enjoy it if you just go log in, and you can enjoy all these things, especially the galleries, which gives our past memories with conferences. Thank you.
Thank you so much, sir, Dr. Agarwal. You must be poured your hearts in developing this website. We, on behalf of the entire Eizoc society, do congratulate you for this efforts. With that, we come over to the most honorable portion of our program today. May I invite Dr. Ranjana Kumar to take over from this point. Dr. Ranjana Kumar, please.
Thank you, Dr. Das. Good evening, everyone, and a warm welcome to all of you to Dr. Arvind Jaiswal Oration. I request And it's my humble request to our distinguished chairpersons for this ceremony to join us on the virtual platform. My humble request to our President Eizoc, Dr. Abhijit Ghosh, Dr. Arvind Jaiswal, Dr. Partha Biswas, Chairman Scientific Committee of the All India Ophthalmological Society to join us, Dr. Pranav Ranjan, Secretary Eizoc, and Dr. Debashish Das, Chairman Scientific Committee of Eizoc, to kindly join us on the virtual platform. Today, I shall share my screen. Today's oration honors Dr. Arvind Jaiswal, a stalwart of Bihar Ophthalmological Society, which is one of the largest constituent states of the Eastern India Zonal Ophthalmological Congress. Dr. Jaiswal graduated from Ranchi University and completed his postgraduate training from Patna University in 1985. He laid the foundation of modern retinal practice in Bihar, Jharkhand state after his Vitro Retina Fellowship from Retina Foundation, Ahmedabad, and RP Center, AIMS stint. An academician par excellence, he has enriched generation of ophthalmologists with his presentations, instruction courses, and didactic lectures in numerous provincial, zonal, national, and international conferences. It is indeed a privilege, sir. And it is a moment of great pride and honor for us that Dr. Arvind Jaiswal Oration for Eizoc MidCon 2021 is being delivered by an international ophthalmologist of repute, Dr. Stephen Aaron Arshinoff from Canada. He was born in Montreal and graduated from Baylor College of Medicine in Houston, Texas, and completed his ophthalmic training at the University of Toronto, where currently he is professor, Department of Ophthalmology and Vision Sciences. His areas of research interest include OVDs and related surgical techniques, phaco machine design, immediate sequential bilateral cataract surgery, endophthalmitis prophylaxis, and medical outreach programs. He is on the editorial board of the Journal of Cataract and Refractive Surgery and has authored more than 300 peer-reviewed publications and 38 medical textbook chapters with more than 1,100 academic lectures worldwide. Dr. Arshinoff is the designer of the Ontario Medical Association Canadian National Institute for the Blind Mobile Medical Eye Care Unit and is the medical director of this program to the north of Ontario, Canada. As I learned that for his innovative ability to deliver ophthalmological care to the underserved regions, he is a recipient of Outstanding Humanitarian Service Award from the American Academy of Ophthalmology in 2020. He is the founding president of the Toronto Ophthalmological Society, the Eye Foundation of Canada, and the International Society of Bilateral Cataract Surgeons. He has also been past president of the International Intraocular Implant Club, which is the parent society of the American, European, and all other societies of cataract and refractive surgery globally. A very warm welcome to you, sir. And I now request our esteemed chairpersons, our distinguished president, Abhijit Ghosh, sir, to felicitate him for this oration. And I request all the other chairpersons to kindly join him. I request our president to kindly read out the oration, the citation for appreciation.
This is the plaque and the medal that will be couriered tomorrow to Canada. And Dr. Steve, in coming couple of days, will receive this plaque and the medallion from East India Zonal Ophthalmic Congress. Sir, President, sir.
You can read it for me, one of you.
Yes, sir. Yes, sir. You want me to read it, sir?
Yes.
This medallion and this plaque is being presented.
The medallion has one more slide, perhaps.
Yeah. Both of them is being presented by the president and the office bearers and members of East India Zonal Ophthalmic Congress. The certificate of appreciation is presented to Dr. Steve Arsenault of Canada in grateful acknowledgement of his distinguished and invaluable services rendered in delivering Dr. Arvind Jaiswal Oration on intracameral antibiotics, how to administer and which drug during the 5th MidCon virtual conference, thereby contributing immensely to the prestige and success of the occasion. Presented on the 31st day of July in the year 2021. Signed by President Dr. Abhijit Ghosh, Honorary Secretary Dr. Pranav Ranjan, Chairman Scientific Committee Dr. Devashish Das. So,
Thank you, sir.
Ranjana, can I add a word to Dr. Arsenault, if you allow me, please?
yeah.
Definitely, sir.
Yes, sir.
We can have the screen. We can have the basic screen actually.
Okay, thank you, sir. I'll stop sharing.
Dr. Arsenault, I would like to apprise you about our association, which is very important. We are an association of the Northeast Indian states, which is quite a big state, large states. And we have a lot of members with us. And this association has been working for a long time for ophthalmology and the cause of ophthalmology in the whole throughout the country. So it is very important. And you know one thing, Northeast states are very important and relevant in India because both the medals have been won in the Olympics by Northeast girls. So this is very important for us. North is very important. And we are, as you know, as I had a word with you yesterday, you know that we are one of the most cordial people in the world. And you will know it better with your experiences in Calcutta. So we hope to have a long association with you after the Eizoc also. And let us have a wonderful future together. Thank you, Dr. Steve, for coming.
So may we request Dr. Steve to say a few words on the occasion, sir?
Okay, well, Dr. Ranjan, Dr. Kumar, Dr. Ghosh, I'm somewhat overwhelmed. It's a tremendous honor for me to be present at your meeting and to give this lecture. I've told some of you, but perhaps only a few, and I should tell you all. It's very strange as a Canadian from this small country, a big country geographically, but very small in population, where we have 17 universities that train ophthalmologists. And I've been to India, I think, a dozen times, and I've been to Calcutta and different parts of the country. And I am overwhelmed by the fact that you have something like 1,762 training programs in ophthalmology, and yet you still invite a foreigner to come and speak to you. I'm just amazed at the quality of work I see in India, and I'm deeply, deeply honored and flattered to be invited to speak with you. So I think we Canadians perhaps do a few small projects here and there, and we'll talk to you about what we do. But I'm truly impressed with the work that you do, and I'm really honored to be invited. And I thank you very much. Shall I continue?
Sir, just if Dr. Arvind Jaiswal, who is also there, if he wants to say something, sir, just few words.
I am overwhelmed. Dr. Steve, welcome to the India and to our society, the Eizoc. I am just waiting and praying to the God that everything comes right. Then we will have a physical meeting with you and our society. With
Thank
good
you.
wishes, thank you.
Thank you, Arvind Jaiswal, sir. And over to Devashish Das.
With that, may I invite Dr. Steve Arsenault to deliver our first Dr. Arvind Jaiswal oration on intracameral usage of these medicines. Welcome.
Okay, well, thank you much. I sincerely hope to be able to return to that part of India again when the pandemic is over. I really enjoyed going to Calcutta before, Kolkata now. It's a beautiful part of the country and really interesting for me to come to. So let me share my screen.
Yes, sir.
And then I will. Okay, can you see my presentation now?
Yes, sir. Yes.
Okay, great.
Absolutely fine.
All right, so I'm going to talk to you about intracameral antibiotics because I think that the literature and discussion has been somewhat confusing. So I'm going to talk to you about intracameral drugs, how to administer them, and which drug to choose and why to do so. These are my financial disclosures. I make no money from intracameral antibiotics. I may appear a bit biased, but I think all of us who do this for a long time are biased with our own work. Okay. First, I'll say I'm very honored to give the Dr. Arvind Jaiswal Oration. You gave me this slide of his stellar record, which I reviewed, and I'm really impressed. The first thing I did is, in the background there, I got a map of India to find out exactly where he's from. So now I know exactly where you happen to be located. This is probably the first time I've given an oration of this type where the person for whom it is named is in the audience. And I'm deeply honored that you're listening to me, Dr. Jaiswal, because I don't know if my achievements are as good as yours. So thank you for paying attention. So I want to start at the beginning. So we're going to discuss intracameral antibiotics. We should start off with what our choices are and then decide how we go from there and what we end up with at the end. There initially were 5 drugs, and I put 2 in gray because they've dropped out as being not as good as others from the same class of drugs. And so we had the complex glycopeptide vancomycin, the cephalosporin cefuroxime, and the 4th generation of fluoroquinolone moxifloxacin are left for us to choose from. So how do we choose from those drugs? Well, the simplest way to look at them is that 2 of them, vancomycin and cefuroxime, are time-dependent drugs. And we know that time-dependent drugs, which require a certain exposure to the bacteria to be effective, are less effective for intracameral use than concentration-dependent drugs, where if we achieve a certain level, that in itself, even for a very short time, is adequate to kill the target bacteria. And moxifloxacin is the only one of these 3 current drugs we're arguing about that is concentration-dependent. And then we know if we look at these available antibiotics, that they all have good and bad points. So we know that vancomycin, which was a drug I first used starting in the 90s, well, in Canada particularly, Canada likes to use generic drugs because we buy them from companies who make them locally for much less money. And they forced us to use only generic vancomycin in 2003, which even the company told me causes TAS before we used it. So it was known to be a bad drug. And so I smuggled in the Lilly vancomycin for a while and then realized I had to find a new drug. And as I was doing that, we ended up with the problems of HORV and a few other issues that made vancomycin a not very desirable drug. It's complex to dilute. The CDC advised us against using it for prophylaxis because it's an agent of last resort being reserved by the world for more severe diseases. So it's kind of not a really great drug for us to use. And then the ESCRS came up with cefuroxime, and cefuroxime really was taken by them from a Swedish study. And the problem with cefuroxime, simply put, is it doesn't cover many gram-negatives, particularly enterococci. And the latest Swedish studies looking at the database in Sweden shows that a certain proportion of patients will get enterococcal infections, and they almost universally go blind because the drugs we treat the infections with don't kill enterococci very well, and it's a very aggressive drug. And that is aside from the fact that it's complex to dilute, although now we can buy it in multiple use pre-diluted solutions. They've had issues of contamination, allergy, anaphylaxis, and various problems, as is a penicillin-like drug, and so you get more allergy and anaphylaxis. So moxifloxacin was the drug that I chose in 2003 to replace vancomycin. And the nice thing about it is it's dose dependent. So you can keep giving a little bit more if you get resistant strains, and it will kill all of those strains. There have been reports of anaphylaxis to topical moxifloxacin, one case in the world. There is concern about possible retinal detachment rate increasing if you give it systemically for a long time. There's a syndrome of BATE, bilateral iris transillumination syndrome, reported by Janet Davis, that I'll talk about later, and another issue. But basically, moxifloxacin of all of them appears to be the safest drug and perhaps the most effective, but let's look at it more carefully. So if we're going to look at this, we have to look at problems of our previous assessments. A lot of the papers that you read, if you look at them carefully, they're not exactly correct. Then look at the comparison of the choices we have and the issues arising that we have left to discuss. And I'll go through those things in those orders. This may appear redundant, but they're not really. They're issues that arise sequentially as we go through the discussion. So the first problem is, if you're an engineer and you want to go build a bridge across the Ganges, the first thing you're going to do is you're going to study the soil and look at failures before and all kinds of problems. And engineers are always taught to do failure studies to see why anything in the past that was built could have had a problem and get around it. For some reason, we don't do that very well in ophthalmology, but we should look at that. And if you look at that, you see that if an infection occurs with intracameral Vigamox, it will most likely, and actually almost certainly, be a moxifloxacin dose-dependent resistant, so it would have been sensitive with a higher dose, coagulase negative Staphylococcus. And it's almost invariably sensitive to the usual endophthalmitis protocol of vancomycin and ceftazidime, because they're very different drugs that work by different routes. And so usually you don't get a bacteria resistant to everything. It's resistant to certain things for which mutations allowed it to be resistant, but not to everything. And so you tend to get a good visual outcome even in your failed cases. However, with cefuroxime, we have bacteria that are absolutely resistant, things like enterococci. And when you get infected with that, because cefuroxime is a drug that is similar in its mechanism of action to both vancomycin and ceftazidime, usually the endophthalmitis protocols don't work terribly well for enterococcal infections, and the patients usually go blind. So the failures with cefuroxime are worse than the failures with Vigamox. The second problem is the reported MIC90s. When you report MIC90s in microbiology, and by the way, I have a degree in microbiology, so I'm not making this up, the way you derive that is very important to consider. So both vancomycin and cefuroxime inhibit cell wall synthesis, and both of these two drugs, by coincidence, have MIC90s for the target bacteria endophthalmitis that are exactly the same, 2 micrograms per mil for coagulase negative staphylococci. But there's a problem with these because you have absolute resistance of some bacteria. And what that means is they tend to be regarded as not covered. And when the MICs are calculated, they omit considering these bacteria, either gram-negative vancomycin or enterococci for cefuroxime. And so when you drop out some bacteria from your consideration, this MIC looks better than it really is. It really means that the bacteria in the eye, when we don't know what the infection is going to be, are likely worse than this, not likely better than that. But with dose-dependent antibiotics like moxifloxacin, because it kills everything in a high enough dose, because it attacks DNA enzymes, the resistance is only relative to the dose. So when you report the MIC, you tend to look at articles saying we keep getting more resistance requiring higher MICs. That means you're looking at the 2 or 3 most resistant cases in the world and what the MIC was of those bacteria. But you see, you're cheating in how you decide this compared to how you decide these. So in reality, we should look at the MIC of the standard methicillin-sensitive Staph aureus and not the ones that are more resistant as the usual target bacteria, and then increase our dose to take care of the ones that are more resistant. So the way we report the MICs in moxifloxacin is very different and makes it look worse than the way we report MICs for vancomycin and cefuroxime. And we have to try to correct that so we have a more fair comparison of the drugs. Next problem is why did everybody start administering 0.1 mil? Well, we got 0.1 mil from retina surgeons who try to inject drugs into a very confined space, and everyone kept using 0.1 mil. But the problem is, when you inject 0.1 mil into the anterior chamber, it's not easy to be accurate. And when you're not accurate, you may give a little more, or you may give less, or some may leak out. And in many cases, and often the cases that get infected, we can look back at the case and the story and what happened and the bacteria that grew, and we can reasonably figure out that they most likely did not get the right amount of drug, which was part of the cause of why they got infected. And how about if we want to have enough in our syringe to seal the side port or the incision? We won't have any extra when we use 0.1 cc. So it's kind of illogical in the anterior chamber to use such small volumes. So moxifloxacin is now the most commonly used intracameral antibiotic globally. The Europeans still use cefuroxime, but they're slowly changing. The data from Sweden is showing that they get better results with moxifloxacin, so they might change, and the Swedes are usually the first in Europe to change and the rest copy them. So the first question is, do intracameral antibiotics work? Well, there are numerous studies now all over the world, including about 10 million eyes altogether in these various studies. And every single study shows a reduction of infection rates to 1/5 or 1/8 or even less of what you had before you used intracameral drugs. The largest one comes from Haripriya, Chang, and Ravindran from India, and they had 2 million consecutive eyes and showed extremely good results. Of course, I'm sure you're all aware of that. The only two studies that didn't show that were from Japan, and it's because they only use 100 micrograms. They use less than 1/5 of the recommended dose to put in the eye. So it's not surprising they weren't very effective. I use intracameral diluted Vigamox 600 micrograms in 0.4 cc, which is a little less than the entire aphakic anterior chamber. And so you can wash out the chamber and get a high dose in the eye. I've done over 10,000 cases to date. This dose kills everything, and it's a large enough volume to hydrate the incision, inject it, use the pressure you achieve in the eye when you're injecting to rotate the lens to make it straighter, or whatever you want to do. So that's the one that I think is the best, and I'll show you why. So Marie Ablegare was a fellow in Toronto about 12 years ago, and she is now the chairperson at the Centre Universitaire d'Ophthalmologie in Quebec City. And when she went back to Quebec and took over the chairmanship, she encouraged the entire city of Quebec City to change to do bilateral surgery and to use the antibiotic prophylaxis that I have used for years, the intracameral moxifloxacin diluted, and to use 0.4 cc's. And what's happened is they have achieved an infection rate at 1 in 14,500, which is the same infection rate I reported in 2013 from all the surgeons in the world who chose what we wanted to do for bilateral cataract surgery. So I think this really is an achievable infection rate if you use the best methods of intracameral prophylaxis and you make sure your incisions are sealed and all the other prophylactic things you want to do. By the way, that will appear as a paper which I wrote with Susan Ryuki. It's been accepted by the Journal of Cataract and Refractive Surgery. It'll appear in a few months. So what other paper we wrote in 2019 in JCRS, we looked at comparing vancomycin and cefuroxime, which I told you had the same MICs. You can only have one line then because it's the same amount of drug, versus moxifloxacin when you inject them both into the eye. And these are the curves that you get of how they decline in the anterior chamber. The horizontal lines, the blue ones refer to moxifloxacin and the red ones refer to vancomycin and cefuroxime. And this is the log of the concentration, and here's time after injection. So what you see over here is that when you inject these drugs, they gradually abate over time, which is expected. But the difference between the dose you achieve, the blue line of moxifloxacin in the anterior chamber, and the target dose of the MIC of the bacteria you want to kill is roughly twice as high compared to what it is with either vancomycin or cefuroxime. And this translates over time to meaning that the effective dose of vancomycin in the eye is only half as high as the effective dose of moxifloxacin after surgery. So we really get more or less 40 hours of effective moxifloxacin in the anterior chamber. And the interesting part about this is this top line. The top line is the most resistant strain of bacteria to infect an eye ever reported with respect to moxifloxacin. And we even get 10 hours of anterior chamber moxifloxacin level higher than this particular level. So it's enough to kill the most resistant strain if you use the dose that I recommend, 0.4 cc's of 150 micrograms per 0.1 cc. And so the problem, as I told you before, the difference of resistances. So the next thing we want to look at is what are our choices if we're going to use moxifloxacin to inject. Now I showed the Vigamox bottle because that's the only one we know to be safe in North America, although Sandoz also is a direct copy and actually made by Alcon as well, so it's the same drug, different label. But in India, you have many manufacturers of moxifloxacin. The ones who have been talked about the most are Oramax from Oralab in their studies, and Forquin PFS from Entod, which comes in a pre-packaged syringe for single use. So you can either just give 0.1 ml of this into the eye, and you get 500 micrograms of this dose in the eye, or you can dilute it. Now in this bottle, I actually put in fluorescein because it's more yellow to see, but it's not Vigamox in the bottle. This looks yellow the same. So the first step is take the bottle, put the whole bottle, 3 cc's into a syringe, about a 12 cc syringe, add 7 cc's of BSS, and then what you get is 150 micrograms in 0.1 ml. You then take it and roll it in your hands, and from that syringe, you put 0.6 cc's onto the nurse's scrub tray for each case you're going to do. You aspirate that and you inject 0.4 cc's into the eye through the side port after you seal the incision as the last step in surgery. And if you do that, you end up getting 0.4 mil into the eye, 600 micrograms, and that's enough to kill any bacteria ever reported to cause endophthalmitis. Issues. So there are a number of issues now that if we're going to do that, let's say, is there anything about that? How accurate is it? Is it safe? Is it effective? And things like that. So accuracy. So since I first began to do this many years ago, I talked about using a larger volume. And finally, in 2019, Shorstein and Gardner. Gardner is a pharmacologist with the US government, and Shorstein is an ophthalmologist in California, published this paper saying that smaller injection volumes of higher concentration moxifloxacin resulted in less accuracy and less precision in the delivered dose, which is exactly what I've been saying for years. And it's obviously true. If you use a larger volume, you can be more specific and accurate in how much you put in the eye. So they said this in this paper as a simple experiment, but the real data came from this study by Asena in 2013, which is the one I used as a reference before they published their paper. And what they did is Asena did this in rabbits, trying to look at what is the half-life of moxifloxacin in the eye and how much you get behind the lens because of the previous concern that was published by Janet Davis with this Bates syndrome, which I'll talk about in a second. The interesting thing here was something that was only briefly talked about in this paper, and that is this part, where the graph starts. When they took samples from the eyes of these rabbits at 30 minutes, and they wrote a whole paragraph at how careful they were to make sure the intracameral 0.1 cc of moxie did not leak out of the eye. And when they did that, they found out that at 30 minutes, only 1% of the injected moxifloxacin remained in the eye. And the reason, of course, was because the rest leaked out. And so when you look at that and look at the data, the rest of these graphs, the slopes are correct, but you lose a lot of intracameral moxifloxacin when you inject only 0.1 cc through a limbal incision. So the Bates syndrome. Janet Davis and her group published this in 2013, also a big year for moxifloxacin. And what they did is they looked at people that were in ICUs, and if they were in for a prolonged time and got systemic moxifloxacin for a long time, some of them got this syndrome of the loss of the pigment cells on the back of the iris, which caused severe glaucoma, and some of them went blind from the severely high pressures. But then a couple of years later, in 2019, Light and Falkenberry published a case of a unilateral case where this patient had a vitrectomy for vitreous floaters, and the surgeon took the intracameral moxifloxacin and injected it between the iris and the human lens. The difference between a pseudophakic eye and a human eye that's phakic is that the phakic eye has the lens draped upon or the iris draped upon the lens. In an artificial lens, the lens sits back from the iris, and so you probably won't trap moxifloxacin. But in a human eye, it's quite common to have the iris draping on the lens, and so when you inject the moxifloxacin between the iris and the lens, you get a very high dose right behind the lens, and these numbers show you that this syndrome is likely due to sustained elevated moxifloxacin levels just behind the iris. So this patient got this unilateral syndrome of iris transillumination, which occurs suddenly from toxicity to the drug. So doing that is not a good idea. So how about efficacy? Well, in 2017, Libre and Matthews published a paper. They looked at 18 endophthalmitis isolates from the Bascom Palmer Institute. We won't go through the whole study, and they looked at all the drugs that we used to see which works. And they decided that only moxifloxacin was effective against every single one of those isolates. Vancomycin and cefuroxime were inactive against Pseudomonas, and all three antibiotics, even at very low doses, killed streptococci. But to eliminate staph and Pseudomonas, you have to have the maximum dose. The moxifloxacin in the anterior chamber has to be more or equal to 500 micrograms. If you have less, like they had in those two Japanese studies, it's not sufficient to kill off the most resistant bacteria. So then We had another case. We just wrote another paper. When Quebec City began to do routine bilateral cataract surgery, some of the surgeons that were not working at Laval University also began to do that. And this particular doctor took a 79-year-old immunodeficient farmer from rural Quebec and did bilateral cataract surgery, had a rare immunodeficient syndrome, and did bilateral cataract surgery, and gave him intracameral moxifloxacin, but gave him 0.1 cc, probably didn't get an adequate amount into the eye. And this patient developed bilateral simultaneous postoperative endophthalmitis. And he had, again, a resistant, methicillin-resistant, coagulase-negative Staphylococcus grew. But when he was treated aggressively, as usually happens in these moxifloxacin cases, he came out with 20/20 vision when he was sent to Laval where they treated him. So he likely received an inadequate dose of moxifloxacin, another reason why you shouldn't use 0.1 cc directly, and it's better to dilute it and inject more into the eye so you exchange the anterior chamber. The second series was from Norway. In 2019, there was an unusual, weird series of Burkholderia post-op endophthalmitis, where there were 5 unilateral and 1 bilateral infections from a surgeon who does routine bilateral cataract surgery. And this happened through the ventilation syndrome in January because there was a very unusual thaw in the Arctic due to the Gulf Stream. It rained like crazy, melted all the snow, and for a week in January, the Arctic was growing green. And so when the snow melted, all of this Burkholderia, which resides in very cold soils and stuff, got into the ventilation system, and Burkholderia contaminants got into the ventilation of the operating room, and these patients got infected. And they were eventually treated, but they all got cefuroxime, but cefuroxime is not a particularly effective drug. It doesn't kill Burkholderia. Moxifloxacin does. It turns out that fluoroquinolones are used orally in Burkholderia cases to get a high dose in the eye to kill these things off. And they gave the patient vitrectomies and treated them, and they all recovered 20/25 vision or better. This is, as far as I'm aware, are the first cases of Burkholderia endophthalmitis that actually achieved good vision after treatment. So they did very well. But here again, you would have been better off if you'd given them a higher dose of moxifloxacin than giving them cefuroxime. So we did a paper which just got published looking at, if we're going to do that, is there any benefit of giving topical drops or oral antibiotics? And we just published that in the Canadian Journal. And we drew these graphs. And here's the same lines I showed you before of the resistance lines. And here's what happens when you inject the intracameral. The blue line is the intracameral moxifloxacin. And here's what happens if you give 1 drop every hour postoperatively. Initially, nothing happens, but after about 10 hours, you see that the intracameral level is decreasing, but the topical drops will keep this about 4 times higher than the level that is cidal for all of the staphylococcal bacteria, except for the 2 most resistant strains ever found in the world. But no one's going to give drugs every hour. So if you give it 6 times a day, you're going to stay above the mutant prevention concentration for as long as you keep giving the drops. If you give it only 4 times a day, it's going to go back and forth across that MPC level. You'd like to stay above the MPC level. So what's the point of giving drops? If you give patients topical moxifloxacin 6 times a day for 3 or 4 days post-op, you will maintain a level of antibiotic in the eye sufficient to kill all but the 3 or 4 most resistant strains ever found in the world of endophthalmitis. And if the patient rubs their eye and gets a transient wound leak at 1 day post-op or whatever, you'll prevent that patient from getting an infection with the most usual bacteria that cause infections. So my practice is to give patients a bottle of moxifloxacin and tell them to take it 6 times a day for 4 days post-op. And I've gotten no infections that way, and some have rubbed their eyes and done things as normal patients do. So how about if you give them oral moxifloxacin 12 hours before surgery and again at surgery? So here you see the same line of the declining levels from the intracameral, and then you see these 2 lines. This one over here, the dotted line, is what happens if you also give oral. The main effect of this is if the patient was in a motorcycle accident or a car accident and came in with a damaged eye and a systemic infection from whatever he got damaged in the accident, this level will actually be protective because you get absorption of moxifloxacin given orally into the entire body. And as it slowly decreases from the tissues, some of that goes into the eye. And you see that after the first 24 hours, you get a higher level than you would have just given the intracameral one. So the only time you're ever going to get a benefit from giving oral antibiotics is if you do that in addition for a patient who had trauma or has a systemic infection, and you keep that from going into the eye. But that's all it does. It doesn't do anything else. So for routine patients, it's useless, but for patients who have another infection, it may be helpful. So the summary, I made a table here of the issues. The concentrations are different if you do it straight from the bottle than if you dilute it. The volume is 0.1 cc's from the bottle, which is hard to administer accurately, 0.4 cc's if you give it diluted. The total dose administered is better if you give it in 0.4 cc's. It's more precise to administer, the safety is better, and the efficacy is better. So it turns out, if you look at all the issues, moxifloxacin is the best, and 0.4 mils of diluted moxifloxacin covers the most resistant, methicillin-resistant, coagulative negative staphylococci. Diluted moxi is more precise, it's safer, and more effective than any other drug we have. Topical moxifloxacin 6 times a day for 3 or 4 days post-op reduces the risk of infection, particularly in patients that aren't particularly compliant. So in summary, that's what I use. That's what I promote and talk about. If we get a better drug tomorrow, I'm more than happy to change. I changed before from vancomycin, and I think we should all look at what's available and be prepared to change, but try to use what we think is the safest based upon all the literature and evidence that we currently have. So that's the conclusion. I want to thank you very much for this great honor, being able to present to you. And I love India. I love coming there and I love speaking with you. And I think you have a very vibrant academic society, and it's a great pleasure to be involved. Thank you very much.
Thank you very much, sir. It's absolutely fascinating. I'm overwhelmed. Usually, orations are not followed by any questions, but I'd like to have a short comment from our president, Dr. Abhijit Ghosh, followed by Dr. Pranav Ranjan, sir. Sir, you are muted, sir.
Many of us have been using moxifloxacin now, but I think many more use topically than intracamerally. That's my observation, of course. Well, it's a wonderful drug. Let's see what happens in the future. We'll have much more drugs, I suppose. See. But still now, I agree with you. It's possibly the safest and the best. Thank you.
Sir, I have been using intracameral moxifloxacin for the last 12 years, sir, in each and every case, sir. 0.1 ml, Vegamox, that is the only drug which I have used. And from today, what I have seen, I'll change my strategy. But I can confess that for last 12 years, I have been using intracameral moxifloxacin in each and every case. And probably, I don't remember a case of endophthalmitis in my operation theater as of today in the last 12 years.
I agree. It's a wonderful drug. And, you know, I don't get any money for it. I found it because I was desperate when we couldn't use vancomycin anymore in 2003.
Initially,
I began to look at all the drugs, and it looked like the best drug in terms of its profile.
Initially, basically, I started with high-risk cases like diabetic cases and all in 2008, 2009. So then I thought, if I am using it in high-risk cases, why not use it in all cases? I mean, literatures were not available there at that time. But I go to sleep nicely when I put in intracameral moxifloxacin. This is my observation.
I did the same thing. I can tell you that when I started in 2003, I think the first few patients, after checking around the world with pharmacologists and other people, because I was afraid to use a drug that had been untried, and we got consents from the patients. And the first patient I gave 50 micrograms. I gave less than 1/10 the dose to see if it was toxic. And I did like 4 or 5, and they never did great. So I went to 100, then 200, and looked at the pharmacology. It took a couple of years to decide on what the optimal dose was. And I've been extremely happy with how efficacious it is.
Dr. Steve, what is your protocol? Do you use the preoperative topical moxifloxacin also?
No. My talk was limited in time. So one of my other points about it is this. When you give a patient 3 days of topical moxifloxacin, for example, what you do is you kill off the sensitive bacteria on the conjunctiva. What that does is it leaves all the conjunctival nutrients available for another bacteria to start to grow in the conjunctiva. So anything that grows on the conjunctiva when a patient, remember bacteria multiply every half an hour. So if you're going to leave that, it's like agar, right? More or less it's a growth medium, the tears and everything else in your eye. You're going to start to grow bacteria that are resistant to moxifloxacin because nothing else can grow when you keep giving them drops. So all you're doing is you're creating a culture on the ocular surface of resistant bacteria. Now, if you're lucky and the patient lives in a very clean house that is, very clean and very good, they don't have an environment that's contaminated. But if you do that, let's say in patients that are hospitalized where you have resistant strains to everything in hospitals, that patient will likely have resistant bacteria on their eye when you go into surgery. So those patients actually have a higher risk of infection than the ones you don't. So what you actually want to do is when the patient comes into the operating room or to your theater, maybe give them 3 drops of moxifloxacin, 1 every 5 minutes for about 20 minutes before the surgery. And that will kill off all of the sensitive bacteria on their conjunctiva at the time of surgery. Anything else you give before is foolhardy and it increases the risk of infection.
And what about povidone iodine? What about povidone iodine wash just before surgery?
It's great stuff. Use it every time. It kills everything. It works by a different mechanism. It doesn't work like an antibiotic, and it's fantastic. And actually, some people are looking at. It turns out povidone iodine is actually more effective in lower concentrations, which sounds strange, but some people are looking at if we can reduce the amount and make solutions to put in the eye after surgery. It may be more effective than antibiotic. And if that works, great, I'll use that. But right now, that's not very well worked out. It's a research project being looked at.
With that, we come to the end of the oration. May I request Dr. Swaraj Bhattacharya, our Joint Secretary, to give the vote of thanks for the oration. Dr. Swaraj, please.
Thank you, Dr. Devashish. The best and beautiful thing in the world cannot be seen or even touched. They must be felt by the heart. Thank you is one such prayer among them. Very good evening, everybody. Respected dignitaries on and off the dais, virtually. I feel honored and privileged to get an opportunity to propose the vote of thanks on behalf of the Eastern India Zonal Ophthalmic Congress for the MidCon 2021. I would like to express my profound gratitude to Dr. Steve Arsenault, who is with us all the way from Canada and consented to be the speaker of the prestigious event, Dr. Arvind Jaiswal Oration in our MidCon 21, sparing your valuable time. Sir, we are honored by your gracious presence and at the same time inspired and enriched by your beautiful speech. My sincere thanks to Dr. Partho Biswas, the Chairman Scientific Committee of IOS, who was supposed to be with us, but due to some urgency, who could not be with us right now. But I know his heart is always with us at the present moment. Thank you, Dr. Arvind Jaiswal and Dr. Ranjana Kumar, to be in the team for felicitation ceremony in addition to the Eizoc office bearers. At the same time, our sincere gratitude to the chairpersons, moderator, and judges of the R.C. Meher free paper oration, both prelims and final round, who has planned for carrying out the job so meticulously. My special thanks to the team quiz, especially Dr. Vibhuti Prasad Sinha and Dr. Shogata Pal, the quiz master of the evening, for arranging the mind teaser quiz, guided by the chairpersons and moderator of the session. My heartfelt thanks to our leader, President Dr. Abhijit Ghosh, for the welcome speech. Your leadership has taught us how to get along with all, even in these odd hours of pandemic. I, on behalf of the Eizoc, take this opportunity to extend our appreciation to our dynamic secretary, Dr. Pranav Ranjan sir, for the excellent organizational capacity and boosting team spirit in all spheres. A big thank you to none other than our young, energetic scientific committee chairman, Dr. Devashish Das, who took keen interest in improving the scientific content and give scope to the young speaker. Our treasurer, Dr. Nagendra Prasad, web in charge, Dr. Jayagopal Agarwal, and our director, our editor, Dr. Sujoy Samanto, deserve special thanks for carrying out their activity even in this odd pandemic. Our deepest appreciation to Dr. Satyajit Sinha. Again, he could not join us right now, but he was one of the coordinators of today's conference and he was all along in all the preparatory meetings. My deepest appreciation to our incoming leader, President-elect Dr. R.C. Meher and Vice President Dr. B.N. Gupta, who are with us right now, and we strongly believe under your leadership, Eizoc will continue to be active and will achieve greater height. Thank you all our participants, delegates, and the guests who has attended in good number to make the conference successful. I wish to express our profuse thanks to the sponsors of today's evening, namely Antod Pharma and Sun Pharma, for offering their support. Lastly, I would be failing in my duty if I do not convey my thanks to the Zoom platform for providing us the virtual platform. Thank you all. That's all from my side.
Thank you so much, Dr. Swaraj. With that, we come over to the most awaited, Dr. R.C. Meher free paper session finals. We had initially 2 preliminary rounds yesterday, and we had selected 6 papers for today's final rounds of presentations. I hope you will all enjoy it. With this, may I invite the moderators for the free paper session, Dr. Suhas Prasad and Dr. Ojasvita Singh, to take over at this point. Before I hand over Dr. Suhas, I'd like to present Dr. R.C. Meher, Dr. R.C. Meher's initiation, as because this is initiated by him. Is this screen okay? So this is Dr. R.C. Meher free paper session. I have a short introduction. He was born on 27th of January 1950 at Belpara in Bolangir, Odisha. He passed MBBS from the VSS Medical College, Barla in 1975. Did his DO at MAMC, Delhi, and did his MD Ophthalmology from All India Institute of Medical Sciences. Previously, he is a member of the Managing Committee of the AIOS in 2 phases in 1999 to 2002, and again from 2011 to 2014. He was the president of the IMA Rourkela City branch, and he was the president of the Odisha State Ophthalmological Society in the session 2010 and 11. Presently, he is the director of the Meher Eye Hospital and Research Institute, Rourkela, and he is the assistant professor at High Tech Medical College and Hospital in Rourkela. He received instituted awards from IMA, Rourkela, OSOS, and Eizoc. He has many publications and research to his credit. He has done his social commitments. He's a life member of ISKCON. He's the president of the Meher Association, and he has constructed 2 temples in his village in Odisha. He received the Lifetime Achievement Award by IMA in the Rourkela City branch. With this, may I hand over the session to Dr. Suhas Prasad and Dr. Ojasvita Singh.
If I may intrude 1 minute, could I request Dr. Steve, if you feel you can stay back, we would love your opinions regarding the papers also once in a while, please, sir.
Thank you.
If it's possible.
That will be great. That will be great.
Thank you very much.
Thank you. Dr. Suhas Prasad.
Yeah, thank you, sir. Thank you very much. I, along with my co-moderator, Dr. Ojasvita, welcome you all to this Eizoc midterm conference for Dr. R.C. Meher free paper session. We have 6 speakers today, 6 presentations. Each presenter will have 6 minutes for presentation and followed by 4 minutes by questions asked by the judges. We have to finish it in 1 hour, so please stick to your time. So without wasting too much time, I will request the first speaker. And before that, I just want to name the judges who are there. Dr. Dipankar Das, Dr. Anurag Misra, Dr. Nirda Maiti, and Dr. Swaraj all are there. So thank you very much, the judges, for you. I think you all are ready to do your job. So I will request the first speaker to present her talk. Dr. Rasmi Chandra will be presenting first, and her talk is tacrolimus versus cyclosporin. So Dr. Rasmi, please.
Full view of the screen.
Sir, am I audible?
You are audible.
Yeah.
Shall I start, sir?
Your time starts now.
Good evening, all. And in the next few slides, I will be presenting my research comparing two emerging therapies over their effect on subepithelial infiltrates in adenoviral conjunctivitis. I have no financial interest in any of the products mentioned. Adenoviral keratoconjunctivitis is the most common cause of infectious conjunctivitis and is a public health menace worldwide. And as if any case of conjunctivitis, the patient presents with red fiery eyes, but within 1 to 3 weeks, 80% of the patient has some form of keratitis, of which multifocal subepithelial infiltrates are considered to be the pathognomic of this infection. These are nothing but the host response to contain the infection or invading pathogen by the infiltration of lymphocytes, histiocytes, and fibroblasts. Generally, the disease is self-limiting and artificial tears and short course of topical steroids suffice for the management. But the problem arises when the subepithelial infiltrates are persistent, causing visual obscuration significant enough for the patient to seek advice when comes the role of long-term topical steroid and hence concerns associated with it like cataract, glaucoma, prolonged viral seedling, superinfections, and recurrences. Because of these limitations, search for alternatives was run and cyclosporin came into limelight, which has been evaluated in different strength, has been found to be effective in steroid-dependent refractory as well as steroid contraindicated patients. Even in this series is topical tacrolimus, which too has been investigated in different strength and compared with steroid as well, and has been found to be effective in steroid dependent, steroid contraindicated, as well as some cases of cyclosporin resistant as well. So both these alternatives are doing wonders in their own space. So what about we have to choose one? So there has been there is not even a single study which has compared these two steroid sparing agents in a single study as parallel arms. So what we decided to evaluate and compare their efficacy in a prospective randomized interventional study conducted at AIIMS Patna. And patients of age more than 18 years, those with a duration of history of conjunctivitis of duration at least 6 weeks with significant subepithelial infiltrates causing diminution of vision with BCVA less than 6/9 were included. Those with active keratitis or presence of any coexisting ocular diseases were excluded. Institutional review board clearance was taken and patients were informed and written consent was taken from them. All oral and topical drugs were discontinued. Preservative artificial tears were prescribed. Basic ophthalmic workup was done after 2 weeks of washout. Patients' symptoms were scored on dry eye scoring system, and then they were randomized into one of the two groups. Group A received tacrolimus 0.03% twice daily, while Group B received cyclosporin 0.05% twice daily, along with preservative-free artificial tears for 6 months. Follow-up was done at 1 month, 3 months, 6 months. And mean change in SEI score from baseline and corresponding change in visual acuity was a primary outcome measure, while the incidence of adverse effect and effect on IOP formed the secondary outcome measures. Symptoms were scored on a scale of 0 to 3 depending upon their severity and frequency. Similarly, the subepithelial infiltrates were scored from 0 to 2 level scale depending upon their numbers. Statistical analysis were performed by SPSS Statistics version 25. Independent t-tests were performed to ensure good similarities. ANOVA was conducted to determine any significant difference in the mean test values over the course of treatment. Coming to the results, both the groups were comparable as compared to the baseline characteristics. Symptom score analysis showed persistent decrease in both the groups, while at 1 month the change was significant as compared to baseline at 1 month in Group A and at 3 months in Group B. SEI score also showed consistent decrease, and it was significant at 3 months as compared to baseline in Group A and at 6 months as compared to baseline in Group B. Corresponding improvement in visual acuity was also appreciated at 3 months in Group A, while it was appreciated significantly enough at in Group B at 6 months. IOP analysis did not show any significant change at any time point of interval in any of the two groups. Non-respondent cases were more in Group B, that is cyclosporin group. Adverse reactions like burning, redness, foreign body sensation were more reported in Group B. Recurrence after cessation of therapy was more reported in Group B as compared to Group A. Coming to the published literature, Literature evaluating tacrolimus has documented that it requires at least a period of 3 months for a significant improvement in BCVA and SEI and Sherman's result. But the cohort of patients they were using were different from what we used in our study. A recent report on cyclosporine 0.05% evaluating its effect on subepithelial infiltrates had documented that it needs a period of over 3 to 8 months for substantial change as compared to baseline. But what we got in our study suggests that there was significant improvement in both the treatment groups at 6 months. However, this magnitude of improvement was higher and quicker in tacrolimus group. So we suggest, according to our study, that tacrolimus 0.03% is seems to be better than 0.05% cyclosporine drop as a treatment of SEIs following adenoviral keratoconjunctivitis because its effect is faster, it's better tolerable, and there is less chances of recurrence. Though our study has limitations like small sample size, short duration of follow-up, and lack of control, but still, it nevertheless it has incited several other questions in also are in mind because these drugs are available in different strengths, different formulations, and have been used for different durations in different studies. So it would be interesting to see their effect on the final effect on efficacy and tolerability by titrating these variable factors. These are my references. Thank you very much.
Thank you, Dr. Rasmi. That was an excellent presentation. Now I will request our judges to put up their questions.
Good evening, Rashmi. That was a nice presentation. But I'd like to ask you, how we have diagnosed adenoviral conjunctivitis? That's very important because see, adenovirus has various strains, okay? Second point is that whether you have seen corneal sensitivity in those cases and what staining you have done in those cases to see the epithelial defect, okay? Your study has a component of epithelial defect for adenovirus. Dry eye is again another component, okay? So can you address this question, please?
So my study included only patients with subepithelial infiltrates. It was only after the acute phase has passed off, the patient has entered chronic phase without any epithelial lesions. Initially, these adenoviral keratoconjunctivitis do mimic sometimes with herpetic keratitis, but then clinical examination forms the gold standard to differentiate between these two. Firstly, it occurs as epidemics and it can be associated with preauricular lymphadenopathy, which we don't find in viral keratitis. And secondly, if in fact, it's beyond my research that if still we have some confusion, then we can go for a GIMSA staining of the conjunctival swab, or best is to culture the conjunctival swab to get the positive agent.
No, culture and GIMSA stain will not do this thing. Since the viral, either a PCR or very rapid
immunoassay.
QV test is immunoassay test is available that you can see. Okay, I believe that you should have a authentic study because these are very, very important when you see in your group of patients. Thank you.
Since you said, Dr. Rashmi, since you said that you had excluded patients who had epitheliopathy, you had only taken in patients who had the subepithelial infiltrates. So what symptoms did the patients have? Because you scored the patients based on their symptoms. Apart from a loss or reduction in visual acuity, what did they have as symptoms?
The patient had glare, they had photophobia, apart from this reduction of vision.
And you said that the duration of treatment that is instituted is 6 months. Now, what I would like to bring about, as a notice, maybe this can be included in a study sometime later, is 6 months is too long a period for treatment of subepithelial infiltrates in adenoviral keratitis. You have two agents, and there's no wonder that both of these work because they're immunomodulators and they should be working. But the issue is, tacrolimus is associated, it has been shown to be associated with cutaneous sarcomas. Cyclosporine, on the other hand, is not preservative-free, so that itself can lead into medicamentosa in some of the patients, and I think you have also seen that. So perhaps from the end user's point of view, somebody who's treating these patients, I think a short course of steroids followed by one of these two agents would perhaps land the patient in better comfort in a faster period of time than either of these two. But I completely agree with you as far as the tolerability is concerned. Tacrolimus, generally speaking, is better tolerated. Whose noise is that? Admin, can you put the iPhone thing on mute mode?
इसको बंद भी नहीं हो रहा तुम्हें टेंशन में लीव द मीटिंग कैसे करेंगे
All right, so yeah, so that's the only point I wanted to make. Otherwise, the originality of your concept is really praiseworthy. Thank you.
Thank you, sir.
Is there any other question, or we can move ahead to the second presenter?
Dr. Rashmi?
Yeah.
Yes, sir.
Yeah. Both are immunomodulator. How do you find the difference in action between these two? Definitely, though, in those cases where steroid responder or those other cases to relieve, we can use either tacrolimus or cyclosporine. How to differently act? What is the mode of difference?
So it's basically immunosuppressive along with anti-inflammatory properties. Both of them has immunosuppressive as well as anti-inflammatory properties, and tacrolimus has been documented to have 100 times more potency than cyclosporine. But that has not been evaluated with subepithelial infiltrates. They have been evaluated on other ocular inflammatory surface disorders like dry eyes, VKCs, and like Thygeson superficial keratitis and like that. But they have not been evaluated on subepithelial infiltrates. That's what my aim of study was to.
Okay.
It has already been documented that tacrolimus is 100 times more potent.
That inhibits the calcineurin phosphate production,
Yes, sir. Yes,
T
sir. Both of
lymphocyte
them
and
act through
others.
the calcineurin inhibitors, ultimately inhibiting the T lymphocytes and breaking the cascades of events leading to release of cytokines which are responsible for these inflammatory cascades.
Fine. Fine.
May I add a comment? May I add a comment?
Yes, sir.
Dr. Chandra, I think, Dr. That's an excellent study. I look at it mostly as a pilot study, which is successful. Tacrolimus is effective. And I think you should continue it and expand the study, and perhaps also have an arm that only got topical fluorometholone, or another arm that got topical fluorometholone and tacrolimus or cyclosporine. But you need a lot of patients. This is a disease that tends to come more from hot countries. In Canada, we see these patients mostly when they come back from Florida after winter. They go there, they come back with these infections. We don't get that many of the severe ones that are from here. But some of them I see with severe SCIs for like 2 and 3 years and suffer like crazy. So I think it's a fantastic idea, and I would like you to expand the study and
Yes, sir, definitely, sir. We are into it, but that's only a part of our study. I think it's many tributaries to search upon. As I mentioned in my last slide, there are so many permutation and combinations we can do with this study.
Yeah, and tacrolimus is finding more and more uses. So great.
Why not to start with tacrolimus if it's more effective?
Yes.
But we have to have some substantial evidences in form of trials and researches, sir.
Yes. So I think that's an excellent pilot study. Thank you.
Yes. Thank you, sir. Thank you, sir.
Thank you, sir. Thank you, Steve, sir, for your golden words and suggestions. So can we move to the next speaker?
We have one more judge, Dr. Subhash. Dr. Aniruddha Maite is there.
It's okay, Devashi.
It's okay. Okay. Carry on.
So I will request the next speaker, Dr. Sneha Batra, to please start her presentation. I think Dr. Maiti has many queries for this presentation. So Dr. Sneha.
Yes, sir. Is my screen visible now?
Yeah.
Thank you. So good evening, everyone. My name is Sneha Batra, and it is my proud privilege to present my paper on diabetic retinopathy, fixing the missing link study, prevalence data from West Bengal. Our study was conducted with the help of a research grant from the Academic and Research Committee of AIOS. So diabetes mellitus is another pandemic in which India holds the dubious record of having the second highest number of affected population in the world. And even though it is said that the prevalence of diabetic retinopathy is lower among Indians as compared to the Western population, it is the sheer number of people affected which makes it one of the heaviest burdens in the times to come. As we can see from this chart, most of the epidemiological studies which have been done in the last 3 decades have been done in the southern Indian population. There is very limited literature from the eastern part of the country. I could find only one data from the AIOS study of 2014, which said that the prevalence was around 22.59%. And in fact, our study gives the first DR prevalence data from our state of West Bengal. A total of 39 camps were conducted in 14 districts over a period of 17 months. Our aim was to gather prevalence data for DR among diabetic population in West Bengal, as well as to see if there was any difference between the rural and urban population and among males and females. One of the most unique things about our study was that this study was conducted not in the population or in an eye hospital, but in the diabetologist or the physician's chamber, making it one of the first of its kind prevalence study for DR in India. On the day of the camp, the physician's chamber was visited by a team of an ophthalmologist, optometrist, and a counselor. We included all patients with a known history of diabetes mellitus and excluded those where significant media opacity did not allow fundus evaluation. On-field screening of diabetic retinopathy and grading was done by an ophthalmologist using an indirect ophthalmoscope. Simultaneously, a fundus photograph was also taken with the help of a fundus on phone camera, and these images were later analyzed by another ophthalmologist masked to the on-field ophthalmologist grading. Statistical analysis was done with the help of software R. A total of 1,553 subjects were screened, maintaining a rural to urban ratio of 60 to 40. In our study, the prevalence of diabetic retinopathy was seen to be 21.51%. But what was most shocking was that, contrary to expectations, the prevalence in the rural areas was almost double that of the urban areas. The prevalence of diabetic retinopathy went up with diabetic age, but there was no significant difference between males and females. A very interesting thing to note was that the control of the systemic disease itself was related to whether or not the patient was aware that diabetes can be a cause of blindness. It was very dismaying to note that despite the fact that all of our subject set was under the treatment of a physician or a diabetologist, more than 33% remained unaware that diabetes could be a cause of blindness. This figure was even worse for the rural areas. This highlighted the fact that somewhere there is a missing link between the treating physicians and ophthalmologists in our state. The awareness of diabetic blindness became better with diabetic age, probably after the symptoms of diabetic blindness had already set in and the patient had contacted an ophthalmologist. It was also very dismaying to note that more than half of our subject set had not had the recommended eye screening in last 1 year, out of which a substantial 19% had never had an eye checkup since their disease was diagnosed, once again highlighting the missing link between the treating physicians and the ophthalmologists. The last eye checkup rates were worse for the rural areas, and the loss of visual acuity was also more in these areas. So what we want to summarize is that the stark difference between the rural and urban population, which has come up in our study, compounded by the fact that there is an unmet need for specialists in these areas, as well as lower awareness, is going to cause a possible catastrophic increase in diabetic blindness in these areas in the coming years. And the question is, how can we prevent that? The solution lies in understanding this epidemiological chain. We propose that the loss of control of the systemic disease, as well as the lower compliance to eye checkup, all stems from the fact that there is low awareness of diabetic blindness in the young diabetic age group. And this is where this chain needs to be broken. But the question is, who is going to do it? Because at this early stage, the patient has still not contacted any ophthalmologist. The solution lies in understanding that this can only be done by our diabetologist colleagues. And the solution lies in fixing the missing link between the ophthalmologists and the diabetologists and creating robust referral pathways for early screening. The limitations of my study include not classifying patients into type 1 and type 2 disease.
1 minute to go.
And our strengths include that this is the first study giving a direct comparison between rural and urban populations from the same state. I would like to conclude by saying that even though the prevalence of diabetic retinopathy in West Bengal is similar to the rest of the country, the stark difference between the rural and urban areas is a very worrying fact, and it is now imperative to shift the onus of management from tertiary to primary prevention by fixing the missing link between the treating physicians and the ophthalmologists. We would like to acknowledge the help of the ophthalmologists, physicians, optometrists, and counselors who helped in data collection. These are my references. Thank you very much.
Thank you, Dr. Sneha. That was an excellent presentation and an eye-opener for many of us. Over to judges.
May I ask you one question?
Yes, yes, sir.
Yeah,
share your screen.
I'll stop sharing.
Yeah.
Okay.
So from your study, it shows that there is a 21% prevalence in the Eastern India compared to the Kyo study, which we refer to the one of the landmark study in the epidemiology of and the prevalence of diabetic retinopathy. I think the rate is higher in the Eastern India, isn't it?
Yes, sir. Actually, it is very difficult to compare the data from our study with the other studies because the subject set is very different. The latest study which came up was the speed study, which showed a prevalence of 32%, much higher. This came up in 2020 itself, but that was taken from an eye hospital. So these are patients who already have eye problems. Now, the population-based studies such as speed and all, which show 10%, 15%, 18%, they again have been taken from the population, which is a completely different set. Now, we are analyzing people who are already visiting a physician or a diabetologist. So they know that they have diabetes mellitus. And this has never been done before. So it is a little difficult to compare the data. But 21% is almost equivalent to the other data which has come up previously.
And what do you think in the Kyo studies also there was a difference between the urban and the rural population, and there also the prevalence was more in the rural population. Is it the lack of awareness only factor, or as you mentioned, the lack of infrastructure or the access to the diabetologist or endocrinologist?
Yes, sir. So it is probably a combination of these, and it is a reversal of epidemiology which is taking place because earlier all these studies, including the SN DREAM study, showed that diabetes and diabetic retinopathy was always an urban disease, and it was more in the urban population. But it was also predicted by a lot of epidemiologists that this reversal will take place because of rapid urbanization, compounded by the fact that there is lower awareness and lack of, as you said, sir, the people cannot reach the diabetologists in time, and they are reaching with much higher grades of diabetic retinopathy. So this is probably already starting in our state of West Bengal, and this is something that the study shows, and we need to be very, very careful about that.
And another striking difference is with the Kyo study is that there was a significant difference between the male and the female population. The male population had more prevalence of diabetic retinopathy.
Very true, sir. Very true. Almost all the studies that I have mentioned, all of them, apart from one or two studies, all of them have showed that males always have a higher incidence of diabetic retinopathy. I have never seen any physiological explanation for the same. And in our study with a 1,500 subject set, we did not find that difference. So maybe some epidemiological...
equal between male and female subjects?
Yes, sir. More or less. So possibly some females are not going to check up, but in our case, it was not so.
Sneha, I have some critical observation in your presentation.
Yes, sir.
In the rural area or the urban area, have you correlated the age of onset of diabetes in both the group? Because that will give a significant result when you analyze the entire data, and maybe if you have a prospective study taking yours as a pilot study, it gives a evidence out of it.
No, sir. The age of onset was not compared. The rural and urban samples were age and gender matched, but the age of onset was not compared in our study.
Okay. Second point is that your data, was it that, for example, 100 camps in rural compared with 100 camps in the urban?
No, sir.
Approximate.
No, sir. So what we did was
equally, you have done a 50 or a number of equal number in the urban as well as because the data, if we compare both urban and rural, whether your data shows equal in the urban as well as the rural.
Yes, sir. So what we initially, when we were designing the study, we wanted to emulate the subject set compared to the census data of West Bengal. So we wanted around 60% of population from the rural areas and around 40% from the urban areas, which is what we got ultimately, and which is what was close to the census data of 2011 of West Bengal. So it has 60% rural population.
Okay, thank you.
Dr. Sneha.
Yes.
Do you feel the missing link can be covered by doing a teleophthalmology by using some NGOs and others? Do you feel it's something important we can adopt?
Definitely, sir. This is something that can be done. And even simpler than that, something which can be done is creating a referral pathway, and even the diabetologist can just give his word of mouth to the patient that diabetes can be a cause of blindness. You must go for an eye checkup. He can have some pamphlets in his chamber saying, showing how a diabetic eye disease can cause havoc. And he must say that you should visit an ophthalmologist and come back and tell me how your eye results were. The simple incidents can actually cause wonders. And if we can have that referral pathways, it will really be good.
And I think even the ophthalmologist should make the practice of doing a fundus examination mandatory for all patients.
Absolutely, sir. So the eye screening that we are talking about is a comprehensive eye screening, including a fundus evaluation.
Even the ophthalmologist miss sometimes.
Absolutely, sir. Very true, sir.
May I comment, Dr.
Came
Batra?
across a report, Sneha, in 2019, which was released by the Union Health Ministry, and they also had quoted, and as Dr. Anirudh also mentioned, all the studies have mentioned that the rural population has more prevalence of DR. So I don't know why one of your slides contained that. It was surprising that we found this. So it was pretty much expected. What we have perhaps not looked at, I don't know whether you've looked at it or not, is in India, particularly in the rural population, there are two striking complicating factors why DR is prevalent in with increased frequency. One of them is, of course, the micral, the release of microalbumin in the urine. I don't know whether you have subjected your patients to that. The other, more importantly, is anemia. I don't know whether you have screened them out. You could have done that quite easily because these patients were screened right at the physician's setup. So it is understood that there would be a laboratory closely associated with the practitioner. So probably you could have done that. You can perhaps still do it if you have the records with you. Just look at the hemoglobin levels of these patients to see whether more of these patients were anemic, which perhaps explains why the rural population has, because they don't give importance to things like anemia. The other thing I just wanted to point out was, since you mentioned no gender difference, what percentage of the female population that you had screened had pregnancy? And if they had pregnancy, did your screening protocol change for them? Because we know that it advances pretty rapidly in pregnant women.
True, sir. But we did not have that in our questionnaire. And because there were a number of ophthalmologists who have screened, it will be very difficult to say what is the percentage. It was a walk-in camp. The advertisement was done 3 days before, and anyone who wanted to come and get their eye checkup done for free could come in. We don't have the data of the how many pregnant women with this.
Right. About the anemia, please look into it. Dr.
Yes,
Steve, I'm so sorry I cut you through. Please
no, it's okay. Dr. Batra, this is a fascinating study, especially for me, because I think I mentioned at the beginning, one of the things that I do is I manage Northern Ontario. We have a whole setup with a transport truck where we go and we examine patients in the remote north of Ontario, a central province of Canada, where there are 0 ophthalmologists. And we started about 15 years ago to bring diabetic nurses, and they would sit in the local hospital building, whatever we could find. And as the patients came to register for us to see them, we would have the diabetic nurse see all of them. And after we examined them, counseled them on diabetes management and care. And then about 4 or 5 years ago, the University Health Network, Toronto General Hospital, wanted to show to Ontario how wonderfully well they were doing in taking care of their diabetics, and wanted to compare the results they had to us on the IVAN taking care of the remote rural population. It turns out we did better. And we did better than all of the very expensive doctors because we had a nurse talk to every patient about following their diet, exercising, and all those boring things for diabetes. So my comment to you is, welcome to the wealthy world. When people stop starving and they start having money, the first thing they buy is food, and the last thing they do is healthcare. And what you're seeing is the exact same thing that we see in Northern Ontario, everywhere else in the world. And I think that you will achieve great results if you get nurses or people that are, diabetic people who work with you to just talk to the people and help them in managing their diabetes. Otherwise, India, like everywhere else, will keep getting more and more people with diabetes, and it will not be well controlled until they learn about diabetic retinopathy and the other bad consequences of long-term diabetes. And we see the same thing in Canada when we get Indian immigrants, of which we have lots. Toronto has about 1 million immigrants. You see that until they're sort of forced into our healthcare system, They have high incidence of diabetes when they eat Western foods and don't take good care of themselves. And I think the females do better simply because females do better in all these things. Females listen better. They're more concerned with how they look than the males, and they just take better care of themselves. And I don't think it's metabolism. I think it's just because they take better care of themselves. That's what we see in Canada. And I'm sure there's no reason for Indian boys and girls to be different than North American boys and girls. And it's a big problem. But I think your approach is excellent, to just get out there and talk to them and see them. So I think that's wonderful. It's wonderful work. Congratulations.
Thank you.
Thank you, sir. I'll request my other moderator, Dr. Ojaswita, to please invite the other speaker.
Now I request Dr. Sayantan Ghosh to please present the paper and to stick on time. Dr. Sayantan Ghosh.
Yes, ma'am. I'm sharing my screen.
Yeah, sure.
Full screen. Your time starts now, Dr. Shantan.
Yeah.
Is my screen visible, sir?
It was visible, but then it went off.
Sir, is it visible now?
Yeah, it is visible. Please go ahead.
A very good evening to my all seniors and my dear colleagues. My study is a prospective study on additional therapy to prevent resistance to anti-VEGF in huge diabetic macular edema. I don't have any financial disclosure. As told by my previous speakers, diabetic retinopathy is going to be a huge cause of blindness as well as a preventable blindness in India and worldwide. One of the mainstay of treatment of diabetic retinopathy, especially with diabetic macular edema, is the ranibizumab, that is the anti-VEGF. But the problem with anti-VEGF, especially in the cases with the DME more than 600 micron, which you're calling it here as huge diabetic macular edema, is that there is refractoriness to the costly anti-VEGF treatment, which causes increasing visual disability and which causes non-compliance to follow up, as anti-VEGF has to be given repeatedly. So what we tried in this study is that we tried to target some other upstream pathogenesis, reduced antioxidant level in capillary wall and RBC morphology changes by simple dietary modifications of vitamin B and C. So our study is a prospective comparative triple-blind randomized control trial. The design of the study, after recruitment in the retina clinic, we did a randomization, had all patients done with baseline serum VEGF level, baseline vitamin C level, RBC G6PD activity and other RBC parameters. And the patients were, as far as possible, age and sex matched, and the morphologies have been checked whether there is any confounding factor like EM, epiretinal membrane or tractional detachment. Those have been excluded. Both of the group has been given monthly intravitreal ranibizumab. One group has been given oral vitamin C and B complex, or the other has been given placebo. Monthly follow-up was there. What was most important in monthly follow-up is that SDOCT was done in 21st day. Serum vitamin C and RBC G6PD levels were measured. 6-month follow-up was done, and the analysis was done with our software. In the inclusion criteria, DME more than 600 micron were included. There was no contraindication for vitamin C or vitamin B complex therapy. In the exclusion criteria, we did exclude RBC polymegathism and systemic complications that may complex or compound the results. Coming to the results, there was a responder and non-responder group. The responder group was defined as the more than 5-letter recovery in the visual acuity test and significant reduction in the CMT. What is most important in these parameters is that there is a higher plasma glucose level in higher huge diabetic macular edema, and there is a male preponderance. This is the basic responder non-responder group analysis. The response was maximum in the responder group in 3 months, and after that it was a plateau. And blue signifies the responder group, and both the supplementation groups have been showing a significant response compared to the control groups. This is a very important left-hand side. There's a gender distribution difference and the CMT level in the study groups. The right-hand side, there is an electron microscopic picture. The upper one is the supplemented group and the lower one is the non-supplemented group. We can see the supplemented group has less acanthocytic pattern over their surfaces, which is absent in the non-supplemented group. Coming to the antioxidant-oxidant ratio in the RBCs, as we are trying to control that too. So we tried to measure it with NAD, NADH level, G6PD level, G6 GSH level, and we found in all these curves that the supplemented group shows a rather balanced to the antioxidant group rather compared to the oxidant group. This is again a representation where we measured the plasma vitamin C level, serum VEGF level, erythrocyte 2,3-DPG level. All these are very, especially this erythrocyte 2,3-DPG level is important because of the RBC flexibility is defined by this level. And we found out that all in the supplemented groups, this was in the favorable outcome. Coming to the discussions. In the upstream, we can see the hyperglycemic environment, which is the basic reason basic reason of any microangiopathy in diabetes mellitus. It causes reactive oxygen species generation, which tilts the antioxidant capacity to the lower side. So the oxidation increases within the cells. It causes oxidation imbalance, which causes lipid peroxidation, which is cause lipid morphology or RBC morphology changes and increased surface roughness of the RBC. I would like to go back to my slide of acanthocytic RBCs, which causes the oxygen delivery capacity of the RBCs to reduce in the capillary especially, which causes tissue hypoxia in the end organ, which will cause endothelial dysfunction. This will cause increased VEGF level. So anti-VEGF therapy actually targets the downstream level of this whole process, where we are targeting with vitamin B and C in the quite an upstream level. Actually, we try to supplement it. And serum VEGF level has a correlation with the response to anti-VEGF injection. And what are the limitations of our study? There's a small sample, so we couldn't construct any dose response curve for vitamin C and others. The biochemical parameters like RBC morphology lacked baseline standardization compared to the ethnicity and the race. Anti-VEGF may have some confounding factors in the hyperosmotic state of the RBC. The take-home message would be vitamin C and vitamin B can be effective supplementation to counter anti-VEGF resistance. So thank you.
Thank you, Dr. Sayantan. Now
Dr.
over to
Sayantan,
judges.
I have 3 straightforward questions to you. First, why you have excluded vitamin D? Because see, in your tissue hypoxia slide, you have shown the basic mechanism how the vitamin C and all those factors help in the hypoxic state. If the calcium would be added there, then it enhances the what you call viability or the supplementation for the pro-inflammation or anti-inflammation. Secondly, in your series, the massive macular edema, whether you have correlated with nephrotoxicity, particularly creatinine level in those patients.
Thank you for the question, sir. Sir, actually, my study is one of the arms of a big ongoing study. It's a study on diabetic microangiopathy, whether there is a correlation, partnership between the endocrinologist as well as the microbiologist and the ophthalmologist. So we tried to do the microangiopathic changes in all these diabetes, kidney, lungs, heart, as well as in the ocular system. Now, this vitamin C, calcium, and vitamin D, they have been found in other studies in the same whole big lot of study that they are having much more confounding factors. For any correlation to find out whether this vitamin is effective in therapeutic doses, we have to have a baseline level. So for vitamin B and C, we do have a baseline level in the Indian population. For vitamin D, age-wise baseline level is not available right now. And there's a huge variation according to the kits. So we excluded vitamin D. About calcium, the variation in the diet causes a serum calcium to go up and down. So it is very difficult to have a long-term view of the serum calcium as a whole. So we can excluded that. About angiostatin and tumstatin, the anti-inflammatory factors, we tried to measure it, but the problem was that, especially with the nephro people, is that those two things are very quickly degraded. So the transport time has to be there, properly transport time, so to measure their actual concentration in the blood. Lastly, the nephrotoxicity level, what is the microangiopathic changes in the kidney? About that, we tried to correlate with different protein concentrations in the urine. So there has to be one morphologic change, and there's one has to be an expressibility change. The expressibility change is only in the proteins. Otherwise, the our kidney excretory factors were calculated, but morphologic changes could not be correlated. So we could not actually correlate the kidney changes in my study, sir.
Okay, thank you.
Chantan, very nice study. Actually, we see this antioxidant effect in the dry AMD. We don't discuss this antioxidant in diabetic macular. Very nice. I just wanted to know whether these cases were all refractory cases, or you had chosen the cases where there was a huge diabetic macular edema.
So because of the time constraint, I could not show the slides. We only chosen the fresh cases without any treatment prior on, and
so
they has to.
You see that it was resistant to anti-VEGF, because if we are not using anti-VEGF, at least in the loading dose, or according to the definition, at least 4 injections, we cannot call that as an resistance to anti-VEGF or a refractory diabetic macular case, isn't it?
Sir, we have some preceding studies in the same institute where we tried to find a formula to find out what is the causes of refractoriness of this anti-VEGF to any macular edema morphologically as well as functionally. So in that study, we found out that this diabetic more than 600 micron can be taken as a cutoff. The sample size was more than 300. And can be the cutoff where the refractoriness was the maximum. From that down till we revised this cutoff of the huge diabetic macular edema. Now, yes, we cannot call it as a refractoriness to the anti-VEGF treatment without giving them. But to have a randomized control trial, if we introduce vitamin B and C after refractoriness of the ranibizumab, the endocrinologist told that then the anti-VEGF level may actually not be comparable to the primary level before starting the treatment, and after giving the ranibizumab, the anti-VEGF may go haywire, and we cannot compare. There could be confounding factors. So the 2 arms has to be started simultaneously. Yes, it is a therapeutic trial. It's not a preventive trial, because the diabetes was established, because the huge diabetic macular edema was established, but we cannot really start the anti-VEGF treatment first, see the refractoriness, and then start vitamin B and C. The endocrinologist told that there can be confounding because the anti-VEGF level, serum anti-VEGF level could reduce, and that too not in a linear fashion for all the patients.
Did you see any effect, or if you use a steroid instead of anti-VEGF? Because these are the cases where we sometimes use a steroid in a treatment-naive cases, where there's a huge diabetic macular edema.
So not in this study, but another study is going on in our institute where we are trying to compare the effectiveness of laser, effectiveness of steroids, especially in the Indian population compared to the anti-VEGF. Because the problem with the Indian population are 20,000 or 30,000 injection to be repeated in a patient to come with the compounded with the transport factor, and the motivation is not there, especially in the huge diabetic macular edema. There is no motivation because the visibility improvement, visual acuity improvement is not discernible by the patient. So the patient just do not appear. So we are trying in different studies, but yes, in this study, we didn't calculate the exact factors. Sir.
Which is exactly why Dr. Anirudh is suggesting the use of steroids, Dr. Santan, I believe, because the macular thickness is more than 600 microns. And we saw from your slides that your patients are young, majority of them. And you cannot, you have a period of 6 months for seeing the improvement. And even if these patients are recalcitrant, if the recalcitrant edema is to the tune of 600 microns and the patient is young, would you allow this edema to stay for 6 months just with vitamin supplementation? Would you not like to give a dose of steroids and reduce it down? Because we know that the more it stays, the more damaging it could be to the retinal layers as well. So that's, I think, what he was suggesting. And I think what he was also suggesting is that if the cases are not recalcitrant or refractory, then that word should be removed from the heading, is what I think Dr. Anirudh was suggesting. I completely agree with him. If they're fresh cases, then maybe you should modify the heading a bit.
Sir, actually, we are continuing with the IV ranibizumab, intravitreal ranibizumab. Yes, we didn't try the steroid in the patients. but intravitreal ranibizumab was going on. Now, whether we can replace the ranibizumab with steroid, and when to replace ranibizumab with steroid, and how to continue with the steroid, this can be incorporated in my study design. But yes, in this study, we did not incorporate these things. So,
Dr. Subhas, please continue with the next.
Thank you, sir. I'm Dr. Ojaswata Contouring. Thank you, judges. Now I request Dr. Tanya Rai Bhadra to please present her paper. Dr. Tanya Rai Bhadra.
Yes, ma'am.
Please share your screen. Your time starts now, Tanya.
Yeah, ma'am, please wait, ma'am.
Okay.
We'll request everyone to keep little short. We can just have little less discussion. Because
Yeah, your time starts now, Dr. Tanya.
Okay, ma'am. Please wait. Okay. So, good evening, everybody. And it is honored that the scientific committee has allowed me. Today, my topic is a comparative study of outcome of newly developed choline-based modified trabeculectomy and glaucoma shunt surgery in neovascular glaucoma patients. I have no financial interest. Neovascular glaucoma is a potentially devastating sequelae of serious underlying ocular and systemic disease, important cause diabetes and retinal vascular occlusive disease. The incidence rate of NVG among the secondary glaucoma was a 9 to 17.4%. Glaucoma surgical procedure, it includes trabeculectomy, glaucoma drainage devices, and cyclodestructive surgery. Aim of the study to evaluate the outcome and the usefulness of a newly developed choline-based modified trabeculectomy in comparison to the conventional shunt surgery for NVG patient. Modified trabeculectomy. It is an innovative new modification of trabeculectomy with an 80 choline sutures that was non-toxic, non-absorbable, cheap and easily available. Reason for the modification, high failure rate of conventional trabeculectomy in NVG patient and cost-effective compared to the shunt surgery. So our modification, first triangular scleral flap dissection, next construction of the choline bed with an 80 choline sutures like an S-shaped manner, making ostium and PI, and next the stage sutures was given. Now come to the mechanism of action. Tenting action of the scleral flap in situ choline suture, facilitating the aqueous outflow, and the mechanical barrier action of the choline sutures lead to the less chances of bleb failure. This is a live surgical video clip of a patient with a modified trabeculectomy. Method, it is a hospital-based prospective interventional studies. Informed consent was taken, approved by the ethics committee of institution, and out of 30 NVG patient, 20 NVG patient underwent modified trabeculectomy and 10 NVG patient underwent glaucoma shunt surgery. And all the patient received intravitreal injection ranibizumab 5 to 7 days prior to the intervention, and period of study 2 years. Inclusion criteria, NVG patient uncontrolled on glaucoma medication, and exclusion criteria, NVG patient with no light perception, patient with a previous surgical intervention, vitreous hemorrhage or tractional RD, patient with a severe systemic or mental disease. Statistical analysis performed with the help of FE-Info, that is the trademark of Center for Disease Control and Prevention. We using the standard normal deviate, chi-square test, and the t-test to evaluate the p-value, and p less than 0.5 was taken to the statistically significant. Now come to the follow-up. 18-month follow-up was done at regular interval, and each follow-up, IP, best corrected visual acuity, number of anti-glaucoma medication, and complication of surgery noted. In our studies, we define success, whether complete or qualified, depending on the control of IP. If the IP is more than 6, less than 21 mm of Hg, without topical anti-glaucoma medication, is defined as a complete, and qualified, that means the IP is more than 6, less than 21, with topical anti-glaucoma medication. In our studies, we define failure that the patient needs resurgery or having visual threatening complication. A multivariate prospective analysis of surgical outcome was done, but mainly based on IP control. This is the comparison of the base parameter. 66.7% patient undergone modified trap and 33.3% patient undergone glaucoma shunt surgery. And the age range, both the group, is 50 to 60. And that was statistically non-significant. Now come to the comparison of the surgical outcome of the patient of the two groups at the 3 months. At the 3-month, the success rate was same on the both the group. But at the 12-month, the complete success rate was more in modified trabeculectomy group, and the qualified success rate was more in glaucoma shunt group. But at the 18-month follow-up, the complete and the qualified success rate was same in the both the group, and that was statistically non-significant. Now come to the comparison of number of medication in the both the group in the post-operative period. In the post-operative period, both the group, the number of medication was reduced, and that was statistically non-significant. Now come to the comparison of the post-operative complication in modified trabeculectomy group. Out of 20 patients, the 2 patients developed hypema and the 2 patients developed hypotony. And in glaucoma surgery group, 1 patient developed hypema, 1 patient hypotony, 1 patient cataract progression, and the 1 patient encapsulated bleb, and that was statistically non-significant. Now comparison of the cost of treatment in Indian rupees, both the groups. So the cost of treatment in the glaucoma and surgery group, the range was 5,000 to the 15,000, where in the modified trabeculectomy group, only the 800 to 962, and that was statistically significant. So as per the published literature, according to the European Journal of Ophthalmology, NBG with an Vitesse MRH PPB with an AGB may reducing IOP more effectively, and the surgical success rate was 76.2% in Ahmed group and 61.9% in the trabeculectomy group. But in our studies, in 18-month follow-up, there is no significant difference was found in both the group, and complete success rate 50%, qualified success rate 20% found in the both the group. So our conclusion, modified trabeculectomy may be considered as a treatment of option in developing countries like India as an alternative to the glaucoma and surgery with a comparable outcome benefit. Thank you.
Thank you, Tania. How many cases of yours had PRP laser done before the trabeculectomy?
Sir, in 30 cases, already PRP was done. All cases, PRP was done. PRP and yes, sir, PRP was done in all cases.
Thank you.
Which
Dr.
gauge
Tania?
of proline
Yes, sir.
you understand? Which gauge of proline suture have you used in this?
Sir, it is 80 proline sutures, sir. 80 proline sutures.
Okay. And how do you look at the effectivity of this particular suture to hold? Because you are creating essentially a structural change in the
Yes,
bed of the flap of the trabeculectomy site. So how do you see it effectively running into years to come? Because we have seen from our experience of course, the 80 is something that we've not been really exposed to, but 90, 10 proline actually gives way. So it erodes and then it loosens. Once it loosens, it will also loosen out the bed.
Sir,
So the
I already used the first I used the 60 proline sutures, but the 60 proline sutures, after the 2 months, there is an extrusion of the sutures, but in 80, there is no extrusion. The sutures is no problem. Suture related no problem in my studies in 18-month follow-up.
How long? It's been 18 months since you started.
Yes, sir, 18-month follow-up.
I think you need a long-term look at this, because to establish this as an alternative, you need to look at it really, really long-term, because after a while, they might loosen and they might lose the same purpose, the very purpose for which you have created that tent. So, I mean, this is fantastic as a concept to start with, but let's see what the years to come reveal to us. I'm very interested to see that.
Dr. Tania?
Yes, sir.
It's a very fantastic presentation. The proline use of proline is very good, but in the time to come, there may be some what Dr. Anurag is telling, this may happen. And secondly, probably if it gets succeed, it's going to replace the collagen implant and others.
Yes, sir.
Fine, thank you.
Is there any other questions? If there are no questions, then can we move ahead for the next presentation by Professor Gyan Bhaskar? Professor Gyan Bhaskar, are you ready?
Yes, sir.
Yeah, continue with your presentation.
Thank you, sir.
Your time starts now.
Thank you so much, sir. Good evening, everyone. Respected chairperson, judges, and I like to thank the whole organizing committee and scientific committee for giving me the opportunity to talk on the topic clinical profile management and outcome in patient of post-traumatic non-resolving periorbital cellulitis. No financial interest, no conflict of interest. As we know, the periorbital cellulitis is the infective process occurring in the eyelid and tissue anterior to the orbital septums, and it may lead to the inflammation, erythema, on examination, tenderness, and warmth, and it may be due to the superficial or deep tissue injury, maybe due to the retained foreign body or insect bite or infection. Sometimes for patient with the post-traumatic cases, orbital cavity and periorbital area can lose unexpected foreign body. It may remain for a considerable length of time without causing consumption sign. However, after initial quiescent period of complication often arises, it may be of granuloma, orbital cellulitis, orbital abscess, osteomyelitis, periositis, chronic venous fistula through the conjunctiva skin. Non-metallic orbital foreign body presents considerable diagnostic difficulty due to the relative translucency. Aims and the study to know the cause.
Can I request everyone else to mute? Who is there? Please mute everyone. The host, please take care.
Sir, can I continue, sir?
Yeah, now continue.
Sir, aim of our study is to know the cause, mode of presentation, and treatment outcome. Study design was a retrospective observational hospital-based case series of 14 eyes of the 14 patients done at Regional Institute of Pathology at IGMS Patna. Study subject was patient reported emergency OPD within a day up to 6 months of initial injury with possibility of a retained periorbital foreign body, and it was done from March 2020 to September 2020. Informed and written consent were taken after proper technical and clinical examination. Sir, may I continue, sir?
Yeah, Dr. Gyan, please continue.
I think we can wait. I've just asked the admin to mute him. Yeah, now we can get muted already. Thank you. Continue, Gyan.
Okay, sir. Thank you, sir. Informed and written consent were taken from all the patients regarding the consequences of disease and outcome. Proper history was taken regarding the onset of injury and mode of injury. Proper clinical examination was done with the visual acuity, lead and adnexal examination and done. Ocular movement, anterior and posterior segment was examined properly. And each and every patient was advised for X-ray and CT scan of brain, orbit, and paranasal sinuses. And some of the patient was advised for MRI to know the causes and foreign body. All cases was managed conservatively, followed by the surgical exploration. Removal of foreign body was done, and follow was done on day 3, day 7, 2 weeks, 1 month, and 3 months. All patient alleged history of trauma with non-metallic foreign body was included in the study, and injury with the metallic foreign body, trauma with the multiple fracture with open globe injury, and the study was on corona positive time, so corona positive patient was excluded from the study. This is some surgical procedure of the patient was presented with us with a history of trauma, but without any external sign of any injury. But there is a lead edema and difficulty to open with the discharges, and we externally we did not find any clinical sign of injury. But on high suspicion of we did the CT scan. We see here there is a long foreign body from our orbit to the sinuses was found, and it was removed surgically. And this is a smaller foreign body, which generally we miss, was removed later on, and this is a 7 centimeter foreign body was removed. The second baby was presented with the orbital sinuses, the lower limb, and hardly visible any foreign body in the CT scan. But on exploration, we found that there was a multiple foreign body was seen, and from the lateral foreign body was removed from the lateral inferior orbital rim. These are the few patients which presented with the different clinical presentation with the different clinical presentation, and this is the foreign body was removed. This is a long foreign body, thorn and glass pieces, the stone chips, and also multiple small wooden particle. So all the data were collected and feed on Excel sheet, and it was analyzed. Out of 14 patients, we found that 12 patients were male and 2 were female. Age range from 6 years to 45 years, and duration of presentation of initial injury was within day to the 6 months. And clinical presentation was most common presentation or painful localized swelling in 5 cases, and discharging sinus in 4 cases, orbital cellulitis 3 cases, and lacerated leaf injury was 2 cases. The most common foreign body was wooden stick, stone chips, and glass chips was 2 cases. On culture sensitivity, 4 patients was found to be culture positive. And on after management, 1 patient lost vision due to the patient presented with the orbital cellulitis and exposure keratopathy. But all the patients were recovered well after the proper management. These were the graphical representations, the same on the clinical presentation and type of the foreign body. 36% patient was present with the painful localized swelling, and the wooden particle was most common is 57%. So conclude the in the discussion, most of the metallic foreign body remain present for a long period of time without causing problem. But organic foreign body like would have a much higher incidence of potentially life-threatening and life-threatening complication, and it may be sometimes it is dilemma on a diagnosis due to relative translucency. So patient presented with the delayed granuloma, cellulitis, discharging sinus are the highly suspicious of miss or retained foreign body. These are the literature also available and which are suggestive of foreign body to be diagnostic dilemma regarding the. So conclude that all non-metallic foreign body are the radiologically diagnosed challenge due to their varied appearance and nature and porosity. So in all cases of ocular trauma, prompt diagnosis and treatment is important to minimize the complication. High risk of suspicion always kept in mind in case of trauma, and timely and proper radiological imaging and discussion with radiologists is mandatory. So understanding the anatomic consideration, predisposing factor, microbiology, and evolving management studies should be mandatory for early diagnosis and proper management and prevention of any misretained foreign body. Thank you so much, sir.
Thank you, Dr. Gyan, and we are sorry for the disturbance which was there. So over to judges. You are muted, Dr. Dipankar.
Yes, I think there's hardly anything to comment on this.
Can you hear me?
Yes, sir.
Yeah. Can you tell me the microbial profile of your cases? Have you seen bacillus species in your series? Because there are woody foreign bodies and other things. And
Yes,
what
sir,
is your take-home message of doing an MRI and a CT scan? How you advise? Because there are one aspect there's a metallic foreign body, one aspect there's a non-metallic foreign body.
Yes, sir. After the removal, every foreign body should be sent for the culture and sensitivity. We also expect that there must be some inorganic and fungal in the, but in our study we don't get, because it may be most of the patient or presented with the acute condition and may be on the multiple topical and systemic antibiotic. So, sir, one is the every foreign body should be sent for the culture and sensitivity, and second question is for initially if the history of trauma, MRI should not be prescribed first. After X-ray and on the CT scan is mandatory. If there is a suspicion, if sometimes the wooden particle is not visible in the CT scan also, sir, due to and proper discussion with the clinical scenario of the patient, with a smaller section should be taken and proper discussion. Sometimes we see the split, but it is mandatory to have to go to the radiology department and discuss with the radiologist and see the whole CT plate, sir, not a 2 to 3 single plate. Sometimes we miss in that. So we generally went to the radiology department and see on screen or the whole CT, sir, cuts. MRI only done if there is a suspicion or there is a chance of any other cases, then MRI should be advised, sir.
Okay, thank you.
Dr. Bhaskar,
Yes,
in
sir.
your series, what is the cause of total visual loss in one case you have shown? Why it is so?
Sir, because one patient presented with the orbital cellulitis and orbital preseptal abscess, sir, and also converted with the exposure keratopathy, and there was a periocular area. There is a basically it is the preseptal abscess and orbital abscess, sir.
Okay, but this is a cornea. Ultimately, due to corneal problem, he has lost the vision.
Due to the corneal problem, sir. In spite of
No,
the
no injury to the optic nerve or
no,
something
no,
like
sir.
that?
There is no injury of the optic nerve because it's complicated. In spite of the proper management, there was a multiple foreign body and the formation of abscess. We remove the foreign body, drain the abscess. In spite of there is exposure keratopathy and lost the cornea, sir.
That could be the case, Dr. Gyan, where, as doctor was suggesting, that could be a case where it was infected with bacillus, because we know that bacillus is something that comes from foreign bodies which have been soiled with ground soil, and it causes infection and perforation in all the tissues pretty rapidly. But most of these patients usually have a gram-positive spectrum, as you rightly suggested in one of your slides. They do have a gram-positive spectrum. And the moment we see these cases, we usually treat them with an antibiotic which has got excellent gram-positive coverage. That's the reason why these patients actually go into that quiescent phase, as you had suggested. It is a little unusual for foreign body cases to stay till 6 months. There has to be some amount of negligence involved in there, for which the consultant or the medical fraternity cannot do anything. But I completely agree with you on the modality of imaging in these particular patients, because MRI, if it's done in the initial phases, MRI looks at the soft tissues so minutely that it creates a lot of noise. It is very, very easy for the radiologist to miss the presence of small foreign bodies because it produces a little bit of local tissue destruction, and it's very difficult for them to locate the presence of the foreign body within this pool of tissue destruction, as it creates a lot of noise around. So CT scan is the way to go initially. And if you fail to find and still you have a discharging sinus and you have done repeated investigations and still have not found the foreign body, maybe you can think about an MRI. But it's always easier and a better way, particularly if you have a discharging sinus, to go for a local exploration and see whether a foreign body has been lodged inside or not. Very nice compilation. There was, I'm afraid to say, I don't know whether I'm saying the right thing, but I'm afraid to say that I didn't find anything novel in there, but very, very nice compilation indeed of all your cases. Thank you so much, Dr. Yeah.
Thank you, sir.
Thank you, judges. Any more questions? Now we request Dr. Swikriti Jaina to please present her paper.
Yes.
Dr. Swikriti, please share your screen.
Yeah, once.
This is the last presentation for today's pre-paper session.
Good evening, everyone. I would like to thank Chairman Scientific Committee for giving me the opportunity to present a paper on reciprocity between ophthalmoscopy and B-scan ultrasonography to detect optic nerve head cupping in glaucoma patients. I have no financial disclosure. In present scenarios where cataract surgeries are performed with the least amount of error, there is an increased expectations from patients regarding best visual outcome. In such circumstances, only IOP assessment or pupillary reaction cannot be considered as an indirect measurement tools for glaucoma evaluation. Optic nerve head evaluation is absolutely crucial in these patients. If surgeries are performed in challenging cases of advanced cataract, where visualization is not possible without any optic nerve head evaluation, then the outcome could be disastrous. The aim of the study is to assess accuracy of B-scan ultrasonography in detecting glaucomatous cupping as compared to ophthalmoscopic finding. Materials and methods, a cross-sectional observational study done at a tertiary center involving 30 eyes of 30 patients. Patients with clear ocular media and CD ratio of more than equal to 0.6 were included in the study. Patients with large or small disc, tilted disc, or other optic nerve disorders, and those unwilling to participate were excluded. Study period was from June 2020 to November 2020. All patients underwent ophthalmoscopic examination by 90D biomicroscopy and ultrasound B-scan. A mean value after 10 axial scans were taken. Observer 1 examined all the patients by 90D biomicroscopy and divided them into 4 groups based on clinical cup disc ratio 0.6, 0.7, 0.8, 0.9. The first 2 groups consisted of 7 patients each, and group 3 and 4 consisted of 8 patients each. A second masked observer performed the B-scan USG for each patient to assess the ultrasonographic CDR in those patients. Measurement of CDR was compared among both tools. Chi-square test was used to analyze the data, and p-value of less than 0.05 was considered significant. Basically, a inbuilt caliper in the B-scan machine was used to measure the edges between the optic nerve head excavation. We can see a 0.7 cupping in the correlating B-scan, 0.8 cupping in the correlating B-scan, 0.9 cup with the correlating B-scan. The results, the mean age of the study population was in range of 20 to 75 years, and 19 of them were males. There were 4 groups. Group 1, 0.6 cupping consisting of 7 eyes of 7 patients, 0.2, Group 2, 0.7 consisting of 7 eyes of 7 patients, Group 3 containing 8 eyes of 8 patients, and Group 4 containing 8 eyes of 8 patients. The main USG measured optic nerve head diameter was 1.035, 1.23 mm, 1.38 mm, and 1.61 mm for groups 1 to 4 respectively. On correlating clinical cup disc ratio and optic nerve head cup diameter with USG B scan within all 4 groups showed excellent positive correlation. The Pearson coefficient was 0.87 and p-value was less than 0.001, so it was statistically significant. Now here is a graph against USG cup diameter and clinical cup disc ratio. Based on this graph, a linear regression model was established and a relationship of y equals 1.90x minus 0.11 was obtained, where y stands for estimated USG cup diameter and x stands for observed clinical cup disc ratio. This equation can be used alternatively to estimate clinical cup disc ratio for USG cup diameter. Now there is a table. We can see the clinical cup disc ratio as it increases from 0.6 to 0.7, 0.8, 0.9. The USG cup diameter also significantly increases. Discussion. Glaucomatous optic neuropathy is characterized by selective loss of neuroretinal rim, which leads to increase in cup size, better presented clinically as increased CDR. Although focal notching can occur, it is the increase in vertical cup disc ratio that is more often seen in clinical practice. Newer diagnostic modalities like OCT and HRT aid in subjective assessment of disc morphology and detection of structural progression. These investigations require a clear ocular media and sometimes pupillary dilatation, putting patients with media opacities and non-dilating pupils at a disadvantage. An ultrasound B scan is almost always done for them to evaluate the posterior segment, and a minimal extra effort to measure the optic cup diameter can help in detecting glaucoma. On USG, optic nerve is a regular tubular structure with low reflectivity surrounded by high reflective perineural sheath and heterogeneous orbital fat, making it a good candidate for echographic imaging. This study found an excellent positive correlation between USG cup diameter and CDR as assessed by 90D biomicroscopy in cases of more than equal to 0.6 glaucomatous cupping. Their trend showed a steady change such that a statistically derived formula could predict clinical cup disc ratio from USG measured cup diameter values. The resolution of ultrasonography has evolved with time and now it has become an indispensable tool for assessment of various posterior segment diseases. Thus, its utility in the evaluation of glaucoma cases cannot be underestimated. USG can hence become an excellent tool to decipher the posterior segment pathology in patients with advanced cataract or other cases of media opacity. To conclude, our study has shown an excellent positive correlation between clinical cup disc ratio assessed by an ophthalmologist and ONH cup diameter measured by ultrasound B scan. Hence, proper visual prognosis needs to be informed to the patient, especially in mature cataract cases or lens-induced glaucoma cases, which have increased substantially during the lockdown, wherein if optic nerve head evaluation, if not performed, then the outcome could be disastrous for both surgeon and patients. So we have established here that USG B scan can be a miraculous tool to properly estimate glaucomatous damage in these cases. These are my references. Thank you.
Thanks, Dr. Skruti, for presenting and time. Now requesting judges to please ask the question.
Now, I have a lot of observation to make in this presentation. See, cup disc ratio is not an all phenomenon for glaucoma diagnosis, okay? There are other factors now given importance. For example, neuroretinal rim, etc. Okay, you have compared with plus 90D in slit-lamp biomicroscopy with a observation, which is basically, if you see, it can have a bias because observational bias may be there. Secondly, whether you have compared with a photographic image, okay? Again, B scan ultrasound, okay, does not give an evidence for a small cup or a large cup, myopic disc, okay? These things are very, very important, okay? So this study, it's because, see, nowadays OCT has come up in a very good way. There can be RNFL to see the quadrantic involvement of all these even the ganglion cell layer and IPL layer can be seen in those situations where there's a loss of things are there. Now, this is very, very important, okay? Now, this should not be a what you call mark for your study. I think you should compare with a OCT, newer generation OCT, with all your findings, with the documentation of a disc photography, okay?
Yes. Thank you, sir.
In this context, I like to say, Dr. Jana,
Yes, sir.
Dr. Ramanjit Silota and all, they have made a study. With your study, in addition, the OCT findings.
Yes, sir.
The same what our Dr. Dipankar was telling us, the same
Yes,
thing
sir.
with the OCT. And that
Yes, sir.
also shown the same type of result.
Okay, sir.
Just an information.
Okay, sir.
So what they are saying, the security is that the reason why they're saying this is because since you are fixing cursors in the B scan,
Yes, sir.
measurement of the cup and the disc, you should also fix cursors elsewhere. That would be a proper apple-to-apple comparison. I think to call this a miraculous tool, I quote this because that's what you finished off with in your last slide. To call
Yes,
this
sir.
a miraculous tool, and this would be a miraculous tool, you're right. If we can, prognosticate post-cataract surgery outcomes based on ultrasonographic reading of the CDR, it will be a miraculous tool. But for us to call it a miraculous tool, we have to study it with a proper apple-to-apple comparison. A user or an observer's bias without what 0.6 to you might be 0.7 to me. So that's
Yes,
what
sir.
they are saying essentially. The other thing that is a question to you, and I would like an answer from you. Say, one of the eyes has a hypermature cataract, you can't see anything. The other
Yes,
eye
sir.
has a 0.9 cupping, which is something you can see the fundus and you can see the disc crystal clear. The
Yes,
eye
sir.
that has a cataract shows you, according to your observations, shows you a 0.5 or a 0.6 cup. Would you be
Yes,
able
sir.
to tell the patient that you're going to have excellent post-operative outcomes or not?
Sir, no, because there could be a bias, like while measuring the thing, there could be a bias.
That's exactly what we are suggesting.
Yes,
So
sir.
this study has to be
Yes.
expanded. You have
Yes,
to
sir.
have, I'm aware that the other studies also have very limited sample size, but you expand your sample size and bring us a very good
Yes, sir.
comparative tool, because this is a nice thought, but just work on it a little more.
Yes, sir.
And advance.
Even the
Yes, sir.
post-operative results also, if we go and continue in it, include in the study, that will be more better, I think.
I think
Yes, sir.
right now
Sure,
they have taken in patients who have a clear optical media. They have not really gone into
Yes,
the
sir.
opaque optical media. So it's just in the comparative. Yes. Yeah.
So the idea was like, because in media opacities we cannot do an OCT also, even that is not possible. So the comparison was only B scan could help us in those cases. So
We salute your
Yes,
idea,
sir.
Sukriti. We're
Yes,
just
sir.
saying that if we have a proper correlation,
Yes,
which
sir.
is only possible with the help of an OCT pre-op, and we know
Yes, sir.
that ultrasonographic studies or ultrasonographic observations can tell us or give us important and positive affirmative clues regarding the post-operative outcome, we can effectively prognosticate. So that's
Yes,
what
sir.
we are. Help us
Yes,
get
sir.
those results. Yeah.
Sure, sir. Yes, sir. Thank you, sir. Thank you, sir.
Can I ask one question?
Yes.
I think if the media is clear, the disc photo will be more authentic than the
Yes, sir.
as Dr. Dipankar
Yes, sir.
mentioned. And
Yes,
if
sir.
there is a media opacity, there will be certain conditions where we cannot get the information, like if there is an optic drusen and all. So there will be
Yes, sir.
certain conditions where we cannot apply this.
Yes, sir. So in this study, we have excluded any sort of optic nerve disorders. But yes, if there is an opacity, then yes, sir. Sure.
But nice
Yes.
idea.
Yes. Thank you, sir.
Any more question? Now we have come to the end of this free paper session. Thanks to all the judges for their valuable input. And thanks to Steve sir and all the office bearers for patient listening. Thanks to all the speakers for presenting so well and for sticking on time. Thanks for giving me the opportunity. And now I hand over to the next moderator.
Thanks.
For the
Thanks, everyone. Over to Devashish sir now.
Thank you, Dr. Suhas Prasad and Dr. Ojaswita Singh, for moderating the session so nicely. Thanks a ton.
And thank Dr. Steve. He's spending a Saturday.
Absolutely, sir. Absolutely, sir.
He's
Absolutely,
spending
sir. Only thanks is not sufficient for him, I think.
Don't forget, this is a Saturday evening.
Yes, absolutely. Absolutely. We are looking forward towards our president.
No,
He'll make us celebrate the Saturday evening.
No. But it's not it is a Saturday morning from him.
It's a Saturday
morning.
Okay, so if that's the case, gentlemen, I only commented on the first two papers because I thought I shouldn't try to dominate the discussion.
No.
But I have some comments on the other ones. I think they were all excellent, and maybe I could just take a couple of minutes
Yes, sir.
to
Please
comment
go ahead.
your wonderful
Please,
speakers.
Please go ahead.
So I commented on the first two, and I didn't comment on Dr. Ghosh. And what struck me with Dr. Ghosh's discussion is here's this young guy who's coming, and he has different paradigms from us old guys who learned biochemistry maybe 20, 30 years ago. And he comes and talks to us about looking for upstream changes that may occur. And perhaps someday in the future, when we find out more about this, save up from endlessly, increasingly ridiculous expensive treatments we have for endless injections for anti-VEGF drugs. This is not only a problem in India, it's a problem in Canada too, where the biggest expense now to our healthcare system is endless injections of anti-VEGF drugs to our aging population. So I want to compliment him on standing his ground against the old guys commenting and criticizing, because I think he's on the right track. And I think that in the end, he's going to win. That more research in basic biochemistry and things will probably show us there are other ways and perhaps better, cheaper treatments we can have for severe diabetics and other diseases that we see. So that was my only, I thought I would not say anything then because he was, defending himself against the discussion by the others, and he did a very good job. So it was a very excellent talk. And then Dr. Badra was next, who talked about her treatment with the proline suture within the trabeculectomies as perhaps being able to save money and have another effective treatment in India. But I think as she works on that and as it works, that may be a very good treatment for every country because we all have the same problems. And, shunts don't work forever either. They have problems of some of the shunts damage the cornea over time and all kinds of issues. And if we can find a simple way to modify trabs so that they work better, I think that's terrific. And I thank her for an excellent discussion. And Dr. Bhaskar's presentation, I actually, in wealthy Canada, have seen, I think, 2 or 3 cases like that where I got a patient referred 6 or 8 months after an injury and just wasn't getting better and found foreign bodies. And I had one patient who, my nephew is a radiologist, and a patient went to him requiring an MRI for an unrelated problem. He was in a car accident and got injured. And he sent me the picture illegally over the phone of this patient that I'd seen before. And he said, "Is this a foreign body in his orbit?" And the patient came to me the next morning, and sure enough, he told me that when he was 2 years old, he was fighting with his brother with pea shooters and things, and they were flying these things around the room. And he didn't tell his mother that he got something in his eye transiently and bothered him. And sure enough, he had a foreign body in his inferior nasal orbit that never hit his eye. And, young kids are healthy, so it healed. And now he couldn't have an MRI because of this foreign body sitting beside his globe that I did not notice doing his cataract surgery. I didn't do it through an inferior nasal aspect. And so we took out his foreign body, and sure enough, there it was. And I think that's a common problem that, people don't tell you things or present, and they seem to be okay on a first x-ray and no one investigates. And I think that's a very good point for us to look at, even though it's not new. But when we get these patients, we should look more deeply and investigate them carefully. It's a good lesson for all of us. And finally, Dr. Jenna's presentation, I shared a session at the ESCRS a couple of years ago before the pandemic closed us all down. And we were talking about people who were unhappy after having cataract surgery. And it turns out that every one of us, and probably the leading complaint, was in people who didn't have OCTs before their surgery. And we later found epiretinal membranes or various minor pathologies that may have been missed preoperatively before we did the cataract surgery. And the patients, of course, complained afterwards. And here's another case in patients who come to us with mature cataracts and ask to us, can we do anything? Can we have any idea of how they're doing? And I know in my location, when I get a B scan for a mature cataract patient, I'm told either the retina is attached or it's not. And I'm not told much more because they're afraid to make many more diagnoses. I think this is a really good idea. If we can, have valid ways to look at them and see if the optic nerve is cupped or not, it's one more piece of information we want to know. I would still tell every mature cataract that I really can't promise how well they'll see until I can see their retina post-op. But it's nice to know some idea of what we're looking at. If we see a cupped disc, we know that they have another risk of a bad problem. So I think that's also very contributory to improving our practice. And so I think all 6 of your speakers have really been fantastic, and all have taught not just Eastern India, but me in Canada, how I can do better medicine. And I'm grateful to have spent my Saturday morning listening to them, because I've learned from all of them. And I think you're very lucky to have such bright students and people participating in your meeting, because they all really contribute to us learning. And particularly the young guys. I always like the young ones who come and tell me, you know, you're an old guy and you're doing something wrong. And they're usually right. And we have to listen to our young students who come and give these presentations. You know, we assign them a presentation, and they often come back having reviewed a study, and they don't quite tell us what we want to hear. And so we tend to go and criticize them and comment on their presentation. And we rarely sit back and think, you know, it could just be that that young guy is right. And if we look at them 5 years later, it turns out usually the young guy was right, because they look at it very objectively and don't have the biases we have from our years of practice. So I really enjoyed their presentations, and probably I learned more from them than you guys learned from me. So I'm really honored to be invited to take part in your meeting, and it's been fantastic. So thank you.
Thank you, Dr. Steve, for staying with us for such a long time and giving your good ideas to all of us. Yeah, there was
ideas to change our thinking about the papers that we listened today, because we didn't think in that line in which Steve presented us and forced us to think in that line.
Absolutely correct.
So that is the way we should think, how our youngsters are thinking.
Correct. Absolutely.
Yeah, they don't have our bias, so they just look at it and say, maybe it works, maybe it doesn't.
Exactly.
I think they learned in biochemistry last week or last year tells them more than we know.
Absolutely. Allow me to move over, sir.
Yeah.
Let us move over to the quiz session. May I hand over the platform to Dr. Vibhuti Prasanna Sinha and Dr. Sugato Paul for conducting the quiz. We are running late, but do have your scheduled time. Don't worry about it. Please go ahead.
Chakma. With me, I have my co-quiz master as Sugato Pal, who is a well-known face in eastern part of India. After graduation and post-graduation, he has shifted to UK, and then 2011, he returned back to India. He's working right now as a consultant at Ambri, AMRI Hospital, and Amulya Jyoti Eye Foundation. Has won various awards. And there's also a chairman scientific committee of OSWB. So welcome Dr. Sugato, and he has worked hard to make this quiz a little more interesting. I'm Dr. Vibhuti. So let's go to the rules and regulation. So quiz time, we are already running late by 45 minutes. So chairperson have all the right to stop us at any point of time. Usually we have taken 34 questions, but if you wish, we can sort it to 25 questions. This is an open quiz and open for all those attending, but the prize are for registered Eizoc members only. So if those who are on chair also, if they are not registered, please get registered and participate as registered member, because they are a huge prize that our secretary and president have put in this quiz. The quiz will be played online. The screen of participant will show 2 parts. The quiz master screen will show the questions, and the participant screens through which participant can log in their correct answer will be there. Each question will have 4 options in form of ABCD, what we used to do in our pre-PG days. The participant will get 10 seconds for registering their correct answer. And once the answer is recorded, it can't be changed. So be sure about your answer. Each correct answer is going to fetch 1 mark. After every 4 or 5 questions, we'll try to show you the leaderboard with 10 people on the leaderboard. The first 3 people will be, the name will be actually taken, announced. And then we move on to the next part of the quiz. This is how your screen will look like. This will be the screen where the question will be coming with the pictures and other things, clues. And this is the part where the answer can be registered. So every question will be shown here also with the options like A, B, C, and D. And you can register your answer by just pressing the circle there. So let's now move on to the quiz part. Let's play the quiz. The first part is actually about the Eizoc. And the first question comes here, and this is dedicated to our president. He wanted us to keep questions related to Eizoc. If everyone has seen the inaugural ceremony and heard about the secretary report, they can answer these questions. So how many states are part of Eizoc? And your time starts now. Can Rahul throw the answers also? So the time is up. Let's now see what are the states which are part of Eizoc. This is one of the largest zonal society: Arunachal, Assam, Bihar, Jharkhand, Manipur, Meghalaya, Mizoram, Nagaland, Odisha, Sikkim, Tripura, and West Bengal. These are the states, 12 states which are part of Eizoc. And the 13th states, most probably we are going to welcome Andaman as part of Eizoc. So we now move on to the second questions. May I request Rahul?
May I request Dr. Vibhuti?
Yeah.
The answer options are not appearing on your right-hand side of the screen.
I think there is a lag, what I was saying. Rahul? No, it is. No, it is coming little late. What I'm seeing through my two screens. One is showing through which I have logged in. It is coming late. So what you have to do, you just, the moment I put the question, you flash your answers also. So that by reading time, it will come there. So let's move on to the second questions. Maybe we'll correct this snag here. The first Eastern India Journal Ophthalmological Conference was held in which year? Can we have the poll? Yeah, poll is now showing. So your time starts now. And the first Eastern Journal, the options are A, 1900, B, 2010, C is 1985, and D is 1987. And the correct answer is actually 1985. And when this Eastern India Journal Ophthalmic Congress was constituted, and the constitution was also adopted. So now we move on to the third question. Who was the first president of Eizoc? And your time starts now. Professor Sri Mohan Mishra, Professor Mukherjee, Ramendra Lal Saha, or Chandi Datta. Now things are coming at same time. Yeah, your times is over. So the answer is basically Professor Sri Mohan Mishra. Professor Mukherjee was basically person who drafted the constitution, and Ramendra Lal Saha was the first secretary, and Chandi Datta was the first treasurer of Eizoc conference. Coming to the fourth question, who is the longest serving secretary of Eizoc? Dr. P.B. Datta, Dr. P.L. Saha, Dr. S.C. Das, and Dr. R.L. Saha. And your time starts now. Times is over. And the answer is Dr. S.C. Das, who is nearly one of the longest serving secretary. He served nearly for 15 years as secretary for Eizoc. With now, we come to the end of the Eizoc part. Can Rahul show the scoreboard so that everyone is aware of how this will look like? Rahul, can you show the scoreboard? Okay, that has to be done. Okay, please go ahead. So this is how the scoreboard look like. Dr. Dhira@gmail.com is the leading person. Can you make it full screen? So 3 correct answers by Dr. Dhira@gmail.com. Kaushik Tripathi is 2 correct answers and 1 wrong answer. And Rashmi Chandra is 1 correct answer and 1 wrong answer. So these are the 3 leading person in this quiz. Now we move on to the actual quiz, which will be conducted by Dr. Sugato Paul. Please stop sharing the screen, Rahul. Let me share the screen.
Very good thing which you have done, Vibhuti, thanks.
It is
And,
all
uh,
your all.
Thank you,
all
Professor
your
Vibhuti,
ideas,
for
sir.
the very kind and generous introduction. And I must say it's my pleasure for not running the quiz, but basically having the opportunity to work with you last few days preparing the quiz. We have never met, but we are very good friends now. And thank you, Professor Vibhuti.
That is the beauty of Eizoc.
Yes, that's the beauty of Eizoc. And
Dr. Vibhuti is a fantastic person.
He's
yes,
a fantastic person.
Can we move on to, sir? We are running late.
We are running late, so let's come to the next question. And in this session, we will be identifying the legends. So next slide, please. So name the anatomist after whom the name of the gland of eye is dedicated. Is Francis Jacob, Francois Jacob, Jacob Swan, Jacob Bronowski, and Jacob Anton Moll. Your time starts now. Time is up, and the answer is Jacob Anton Moll, for whom sebaceous gland, modified sweat gland of the eyelid is being named. So next question, please. Francois Jacob, Jacob Swan, Jacob Bronowski, and Jacob. So there is, So name the legend after whom a vessel layer of the choroid is named. Choice A is Herbert Sadler. Choice B is Albrecht von Haller. Choice C, Karl Ludwig Bruch. And choice D is Karl Marx. Your time starts now. And here comes the answer. I hope most of you have got this right. Is Albert von Haller, choice B. Next question is, this picture belongs to Harold Ridley. We don't need to identify him. In which year did he implanted the eye well? 1947, 1948, 1949, and 1972. The choice, your time starts now. Yeah. Because of shortage of time, we are not going to detail explanation. And here comes the answer. It was in 1949, he did first implantation, but a short background, he actually saved a pilot's eye who got injured from splinters, which contains PMMA. And from there, he got the idea that PMMA doesn't cause inflammation. So why don't we try making an eye well with that? And from there, he developed this PMMA eye well. So let's move on to the next question. So who is this famous ophthalmologist legend? Is Reed, Blumenthal, Joshua Elrich, and Charles Kellman. Time starts now. And the answer is, I'm sure all of you have got this right, Charles D. Kellman, choice D. So next question, please, in this session. This is the last question of this section. Slit lamp was invented by Albert von Graffe, Hermann von Hemons, James Hegstrand, and D. Albert Gullstrand. Time starts now. So the answer is choice D. He received Nobel Prize for medicine, but he was a self-taught mathematician who actually worked not only on developing slit lamp, but also correcting astigmatism after cataract surgery. So it was Albert Gullstrand. So after this end of this section, can we have the leaderboard, please?
Rahul, can you say the leaderboard, please?
So
Very well conducted by Dr. Sugato.
I'm sure.
Yeah, wonderfully conducted by Dr. Sugato, these questions. And we are going to learn more. So Kaushik Tripathi is now on the leaderboard. Total answer is 8. Correct 6 questions are correct and wrong is 2. Nitin Dhira is now number 2, and Rashmi Chandra is still at number 3. So these are the 3 leading persons at the end of 9 questions and the 2 part of this quiz. So we move now to the next part. Rahul, please stop sharing your screen.
So the next session is photo finish, where we will be showing some celebrity, and we'll have the questions. So the next question: which one of this following Bond character is almost blind due to terminal age-related macular degeneration? Is Judi Dench, B. Roger Moore, C. Moni Penny, and D. Desmond Alwyn. It is A. Judi Dench. So I'm sure again it's a quiz, easy question for all of you to get it right. We move on to the next question. And identify this famous singer and what was the cause of his blindness. Stephen Wonder with bullet injury, Stevie Wonder with ROP, Harry Belafonte with retinitis pigmentosa, and Jacob Belafonte with post-glaucoma surgery.
And your time starts now.
All easy questions to have fun, and it's a virtual get-together. So I'm sure again, it's an easy one, and it's Stevie Wonder, the famous singer. I just called to say thank you. I just called to say I love you. Stevie Wonder, who was blind from ROP. Next question, name the famous US president who lost his vision in the left eye while in the office. He was in the office, and how? Is James Roosevelt had a bullet injury, Franklin D. Roosevelt, who had a riot trauma during his office time, Theodore Roosevelt, who was injured with a boxing match, and James Roosevelt, who had endophthalmitis post-cataract surgery. The time starts now. Thank you. So it was Theodore Roosevelt who in 1887 actually was fighting a boxing match, amateur boxer, and the president at the same time, and was injured and lost his eye. So next question, please. So find the odd man out in this picture. Bill Clinton, A, Joseph Pulitzer, B, C is Prince William, and D is Mark Twain.
And your time starts now.
Okay, so here comes the answer. It was Joseph Pulitzer, who was blind due to retinal detachment. All the others were blind from color blindness. They had color blindness. They're not blind, but Pulitzer was blind with retinal detachment. The next question, please. Again, who is the famous one-eyed South Indian actor? Rajnikant, Kamal Hassan, Rana Dagwati, and Vijay. Time starts now. And it's Rana Dagwati. He is called the Hulk of South India. He's a famous actor and entrepreneur. So we move on to the next question. So before coming to the next question, can we have the leaderboard?
Yeah,
and Dr. Vibhuti, would you like to take
Hello.
this next slide forward?
No, please carry on.
The last
You are doing it
question
wonderfully.
answer was shown.
Yeah, no problem with
So
that.
whoever has good eyesight can get that.
Yeah.
Can you share the screen, Rahul? Leaderboard. all these questions were quite easy. We try to make it easy for participants so that they get interested. There is a lot of intricacy available involved with this online quizzes, so it was really difficult. So Kaushik Tripathi is still leading, clear lead by 10 correct answers. Nitin Dhira is number 2, and Rashmi Chandra. So leaderboard is still same as the first 2-3 part. Vidya Bhushan Kumar from Patna is now coming close to number 3. So we move now on to the next part. And Dr. Sugato, please carry on. Dr. Rahul, please stop sharing your screen.
So next one is a surgical step. Please identify what's being attempted. Application of mitomycin C at the trap bed. B. Peeling of the inner wall of the Schelm's canal. C. Fashioning of the inner trap flap. And D. Placement of the Ologen implant. The time starts now. So watch carefully and just identify the step which is being performed.
Rahul, please share the answer.
And this is...
Okay. So now move on to the answer part.
Yeah. So this is basically a removal of the roof of the Schelm canal or inner wall of the Schelm canal in non-penetrating glaucoma surgery. So next question, please. Again, this is an easy question. Identify the instrument. The choice are given: cyclodiathermy probe, handheld magnet for metallic foreign body removal, cataract erisphage.
A is cyclodiathermy.
Yes.
Magnet.
B is
This
handheld
pump.
There is some echoing. And D is Kellman first phaco handpiece model. The time starts now. And this was, I'm sure all of you have got this correct. This was cataract, Castrovejo's cataract erisphage pump system, which was developed in 1950, and it was used to do intracapsular cataract surgery. Can we move on to the next question, please? I think we're doing quite okay with time. So next is the implant and injection section. We'll go to the score after completing this section. So the question is, this is a new injection system for target drug delivery. Which space the injection is given? Retrovalvular injection, suprachoroidal injection, intravitreal injection, and transcutaneous injection. Time starts now. Okay, so I hope you got this right. Is choice B, suprachoroidal injection to deliver triamcinolone acinoid, and then it reached the posterior segment quite easily. We can move on to the next question and name this sustained drug delivery system and basically name the drug released by it. Is brimonidine, is latanoprost, choice C is bimatoprost, and choice D is netrosudil. Time starts now. So this is a bimatoprost ring, which can be put topically and can deliver the drug up to 6 months. And studies have shown that it can bring down the pressure, post-washout pressure, by up to 6 millimeter of mercury. We can move on to the next question. Again, name the drug delivery system and the drug delivered through it. Is Retisert delivering fluocinolone acetinoid? Choice B is MATI, cyclosporine plug. Choice C is MATI, latanoprost plug. And choice D is Duracert system delivering ganciclovir. Time starts now. So again, it's an easy one, and it's the MATI latanoprost drug plug, which again has shown to bring down the pressure by about 4 to 6 millimeter. But the problem is they can cause watering, they can fall out, they can chance of slipping within the lacrimal cannula. So these are the disadvantage, but again, is a promising method of drug delivery system. So we come to the next question, next section. Before that, can we have the leaderboard, please? Kaushik Tripathi is a very known quizzer in this part of the world. He recently won in AIUS. He conquered OSWB and probably he's now conquering Eizoc.
Yeah, Kaushik is still leading, and now the lead has increased by 5 marks. So he has given 14 correct answers and 4 wrong answers. Rashmi Chandra has now moved on to number 2 position. Nitin Dhira is number 3 and Vidya Bhushan is number 3. So number 3 position, there is a tie up now, right now. So Rahul, please stop sharing your screen. Yeah.
So best of luck to the other contestant. You have to catch up. Few more rounds left, so you can catch up. So again, an easy section. This one, conquer the cornea. The next question, the question number 20, is which stain is being used? Lysamine green, sodium fluorescent, rhodamine red, and rose Bengal. You can see the red color stain there. So I'm giving you a hint. And the time starts now. It was an easy one, isn't it? Is rose Bengal stain. So we'll move on to the next question. So identify the type of keratophostosis being used here. Is Boston type 1? Choice B is Boston type 2. Choice C is Seoul K Pro. And choice D is OOOKP. Time starts now. So the answer is choice C, COLK Pro. It is advantage of dual fixation. That is the advantage of this ring. So we'll move on to the next question. This, again, an easy one. What is the name of the ring present within the silicon shell of Zepto? Is Zernix ring, Ninitol ring, Tylon ring, and Tensilol ring? A, B, C, D. The option is there. Time starts now. I'm sure everyone will get this right. Zepto is there to deliver accurate centralized capsulorhexis of desired size. And choice B is the right answer. We'll go to the next round. Again, we'll go to the leaderboard later on after this round. So let's identify the syndrome. So question is, these specific findings, you can see the finding on the screen, is associated with one syndrome which consists of all except progressive hereditary nephritis, sensory neural deafness, spina bifida, and anterior lenticulus. Time starts now. So again, this was an easy one. It's an Alpers syndrome, and we have all 3 except spina bifida in Alpers syndrome. It's the answer C is the correct choice. So coming to the next question, again, which is not a feature of this syndrome? Retinitis pigmentosa, hypogonadism, polydactyly, and high IQ. Time starts now. Again, an easy one, and the answer is high IQ. We have shown Lawrence-Moon-Biddle syndrome where the IQ is normally subnormal, they are mentally retarded, along with obesity, retinal problem, polydactyly. So high IQ is the correct answer. The next question, in this case, we are showing an oculocutaneous albinism. You tell us What is the cause of decreased vision in this patient? Commonest cause. Is it amblyopia? Is it retinal detachment? Is it foveal hypoplasia? Or is it CA surge? Time starts now. So it is foveal hypoplasia, which is the commonest cause of decreased vision in this syndrome. So we'll move on to the next question. Again, we are showing the classical triad of this syndrome, which consists of all except is mental handicap, B is epilepsy, C is gonadal hypoplasia, and D is adenoma sebaceum. Time starts now. So again, this was easy one. We showed the syndrome called tuberous sclerosis, which has the classical triad of all the three except gonadal hypoplasia. So the answer is C. There you can have mental hand. Okay, we go to the next question. If we can stop sharing and go to the leaderboard, please.
Yeah, very nicely conducted, Sugatoda, till now.
Just few more questions.
Yeah.
And get through.
Last round is left, so there can be change. Those who are trying to get the prizes and raise the prize money for their own sake, they can work hard. Rashmi Chandra is still at second position with 14 correct answers. Nitin Dhira and Vidya Bhushan, they are fighting neck to neck on third position, and Kausik Tripathi, as you have told, is still leading handsomely. So I think we now move on to the last part of this quiz, where 8 questions are left, and this will decide the winner. So now I'll say the quiz again.
How many total questions are there, Vibhuti?
We have 74
questions,
and we will finish within
34 and 3 questions in case there is a tiebreaker for the first place.
So we will finish in another 5-7 minutes actually.
Okay.
Yeah, so we now move on to the next question. Sugatoda, please.
Yeah. So the next question is on glaucoma. So transient myopia is a side effect of carbonic anhydrase inhibitor, B hyperosmotic agents, C prostaglandin, and D beta blockers. Time starts now. And it's an easy one. It's the carbonic anhydrase inhibitor, which can cause transient myopia by forward moving of the ciliary body. So next question we are moving to. It's a tricky one. How many locations are tested in 10-2 program of field analysis, Humphrey field analysis? Type A is 72, B is 68, C is 84, and D is 28. See, Kaushik is not specialist, so it gives chance to the other contestant to move forward. Okay, so I'm sure most of you have got this right as 68, and it measures up to 9 degrees of the central fixation. We'll move on to the next question. So which tonometer is being used here? Is it Perkins, or is Draeger, or is Goldman, or is Shores? Again, a very easy one. Time starts now. Yeah. Okay, so this is Draeger self-held tonometer, which has been used in space flight for measuring intraocular pressures. So this is Draeger's tonometer. We move on to the mixed bag round. Just few more questions left. So this VIIP project, Vision Impairment and Intracranial Pressure Project, which was started in 2016. Who started this project? Is it Orbis? Is it WHO? Is it NASA? Or is it WNF? That is the World Neurology Federation's research wing. Time starts now and is to see the intracranial pressure and vision impairment. A, B, C, D. Is it World Neurological Federation, or someone else? The answer is NASA. They started the project and this research work is still going on. So we'll move on to the next question. Cilioretinal artery is branch of which artery? Is it internal carotid artery? Is it anterior ciliary artery? Is it posterior ciliary artery? Or is it ophthalmic artery? Your time starts now. So it is posterior ciliary artery. So we'll move on to the next question. I'm sure we'll finish well within time. So what is the slit lamp beam setting in sun grading system? It is height multiplied by width. Is it 1 by 1 millimeter, or is it 1 by 1.5 millimeter? Is it 1.5 with 1 millimeter width, or is it 1.5 into 1.5 millimeter? Sun grading system, slit lamp beam width. So it is 1 by 1 millimeter. Before coming to the next question, the last two questions, we are having the iBanking fortnight in very soon. So this is on iBanking. So the question is, where was the first iBank was started in India and by whom? I'm sure all of you will be able to answer. Is it RIO Calcutta by Dr. C. Archer? Is it RIO Government Ophthalmic Hospital in Chennai by Muthaiya? Is it Arvind Eye Hospital Madurai by well-known Govindappa Venkataswamy? Or is it AIMS New Delhi by Dr. B.B. Dikshit? Time starts now. Think carefully, very easy. Your answer comes now. I'm sure all of you have given RIO Calcutta, but it is actually RIO Chennai by Muthaiya in 1948. And this is actually established in 1918, the second eye hospital in the world after Moorfield in 1818. Moorfield was in 1818, and this was established in 1819. So it has almost more than 200 years old, RIO Chennai. And it was started in 1948. So the last question, if there is no tie-break, is all are contraindication for eye donation except A, HIV, HPV, HCV infection, B, known patient of leukemia or lymphoma, C, any death above the age of 72 years of age, and D, death due to unknown cause. Your time starts now. So the answer is big suspense. It's very easy. Again, any date over 72 years. This is not a clause contraindication for eye donation. They can donate eye even after 72 years. So thank you. If there is no tiebreaker, then that is the end of the quiz. And thank you, Eizoc, for giving me this opportunity to be a part of this wonderful session. So let's share this.
Rahul, please share your screen. So we started a little late. That's why we were a little faster.
Yes,
but we tried to cover. And the leaderboard, as seen right now, shows Richa Gupta, Vidya Bhushan Kumar, and Nitin Dhira. They are at third place with 15 correct answers. So big clap to all three people. Then Rashmi Chandra is at number 2 position, that is 19 correct answers and 13 wrong answers. And still the leader is by handsome margin is Kaushik Tripathi for with a 26 correct answer. So a big congratulations to Dr. Kaushik Tripathi. May I ask chairpersons, can we have the tiebreaker, or we can divide the money into 3 parts for the third position?
I think we will go ahead with the tiebreaker, please.
Okay. So we will have 3 questions more, Sugatoda.
Please have a try.
Please stop this screen sharing, Rahul. Last 3 questions for the tiebreaker. Third, fourth, and fifth. Nitin Dhira, Dr. Vidya Bhushan Kumar. Yeah, third, fourth.
So, can I intervene?
Yeah,
Dr. Vibhuti, he applied for a membership yesterday night. Payment was also made. There was a glitch in the website system. It could not take up, but I have done it manually. And his membership number,
he's basically qualified to.
He is qualified for that. I have allotted his membership number also, EWB0898.
So
that was allotted this morning.
So first position goes to Kaushik Tripathi. Second position goes to Rashmi Chandra. And now there is a fight for third position. Nitin Dhira, Vidya Bhushan Kumar, and Richa Gupta. They'll be playing. Please stop sharing a screen.
And all 3 contestants, make sure you answered the questions. There is no negative marking. I can see there are a lot of people who haven't answered 34 questions. So make sure.
I feel the quiz masters will go for tough questions this time.
Yes, very tough. Okay. So what is the name of this instrument? Is it Icon? Is it iSci? Is it iTune? Or is it iTrain? Time starts now.
Timer is somehow not working, but we'll give 10 seconds. So I'm just checking it. So time is over now.
So this is iSci, which was developed by Moller-Weidel for training purpose. So we come to the next question. Again, an easy one. Identify this device. Is triggerfish contact lens? Is a bandage contact lens? It's a epiretinal implant, and D is cosmetic contact lens with X-factor camera.
Yeah, so your time starts now. I'm seeing it manually on my mobile. 10, 9, 8, 7, 6, 3, 2, 1. Time over now.
So here comes the answer, and it's a triggerfish contact lens. And the last
question. Move on to the last question.
And if there is a tie, we will go for the fastest finger first, which was I'm sure will be there. So what this implant is used for? Look at the implant, and it is used for retinoblastoma. It is used for retinitis pigmentosa. It is used for rhabdomyosarcoma and D, neovascular glaucoma. The time starts now.
Yeah. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Time is over.
So this is a alpha IMS electronic device which is used subretinally, mainly for retinitis pigmentosa and also for age-related macular degeneration. So that's the end of the tiebreaker round. If we can have the leaderboard now. So we started almost 40 minutes late. I think we have made up.
So now we have found out the third position holder. So Nitin Dhira with 17 correct answer and 14 wrong answer is now at the third position. Richa Gupta just missed it by 1 point and Vidya Bhushan by 2 points. So congratulations Nitin Dhira for achieving the third position in this Eizoc quiz. And on behalf of the quiz team, I must say, I must express my thanks and gratitude to our president, Dr. Abhijit Das, then Dr. Pranoranjan sir, CSE, and everyone who participated in this quiz, and Rahul also. There was 3-way coordination. So Sugatoda was working from his place, I was working from my place, and Rahul was working at his place with the admin panel. So it is little difficult and new, and that's why we kept our question level little easier side, so that everyone get interested and there is not much of controversy. So thank you very much, Pranav sir. We'll be sending you and Devashish the result of this quiz. And congratulations to all the winners. And congratulations Sugatoda for working, and it was wonderful working with
I
you.
can see Dr. Avijit Ghosh in the leaderboard as well.
Yeah.
Participating.
So the announcement for the winner is 15,000 rupees. For the runners-up is 10,000. First runner-up and the second runner-up is 5,000 rupees. And
Rahul,
all of
please
them,
save their
all of them,
leaderboard.
I'll be communicating on their email, take their address and their bank account number, and the money will be transferred.
I have taken another decision for the annual conference. The same quiz masters will be there.
Fantastically.
I second
it, sir. Sir, Dr. Vibhuti is the secretary of Bihar Ophthalmic Society, also with loads and loads of work. Not only, and he is head of the department of ophthalmology of RIO. But he will do it, sir.
But he was very, very helpful. He was very helpful.
छोड़ दो, विभूति को हम जब बोलेगा सब होगा. क्या हो? What is he? I'm not interested. हम बोला हो करेगा.
Sir, पटना में नहीं होगा. हाँ ठीक. Okay, right.
Both of you remain, please. Carry on this good work.
This was really fantastically performed.
Fantastic.
Well net, and really proud of both.
Well done.
Well done. Without any
Congratulations. Excellent.
I think our senior Pradutta wants to say something.
No, this is excellent. Hello, can you hear me?
Yes, sir.
Yeah, you are audible, sir.
Audible? Okay. So it's an excellent quiz contest and I enjoyed everything. And congratulations to all the participants who have done well also and who have failed also. But the questions were very nice and well. I am thankful to the quiz masters, all the Subrata Pal and another. And Doctor, I am very happy to see this nice quiz contest. Thank you, sir.
Thank you so much, Dr. P.N. Biswas. With that, let me thank once more to our quiz masters, Dr. Vibhuti Prasansina and Dr. Subrata Paul. Both of them, I know, worked very hard. Till late night yesterday, they were working on it. They even skipped, Vibhuti almost skipped the EC meeting.
He did not answer my questions in the EC meeting.
No, sir. I have sent him a photograph, sir, personal photograph. He has seen that.
He was totally engrossed in the
quiz. Initially, I thought he has gone to sleep. But later on, I realized, he was talking to Dr. Subrata.
Yeah, actually, the last
quiz was not difficult. Yeah,
we had the quiz in the Excel form,
and I had to call Dr. Subrata to draw the attention of Dr. Vibhuti. Marvelous.
Yes. So conducting quiz was not difficult. It was difficult. It was a new experience.
Preparation. Yes.
Conduct it online.
Online.
Coordinate it from 3 places.
Yes.
That was difficult.
And thank you, Rahul, for your help. Thank you, Rahul, for coordinating and for your help. At the
and Rahul, I must have nagged him more than 100 times for the entire program.
Only thing, Rahul, we need a timer next time. Okay, with that, we will move over to the valedictory session. I hand over the valedictory session to my president, Dr. Avijit Ghosh, and to my honorary secretary, Dr. Pranav Ranjan, sir. Please.
Yes, sir. Dr. Avijit Ghosh will start the proceedings of the valedictory session, sir.
I will speak last. Let the others speak, please. How have you enjoyed?
Sir,
I can ask Arvind. I can ask BNR. I can ask everyone, seniors. How? Dr. Meher, you should first say, sir, how was everything?
Unmute yourself, sir.
Sir, please unmute, sir. Sir, you're muted.
Sir, please unmute yourself, sir. Meher, sir. Yeah.
Yes, this mid-conference was really very nice and well organized. And I must give thanks to our President, Abhijit Da, and our Secretary, Dr. Pranav Ranjan, and our Chairman Scientific Committee, Devashish Das. Well organized, and we enjoyed a lot during this pandemic time.
So anyway, this is a well contact through our members, through our office bearers, and definitely this is a very good steps taken by our Eizoc. Thank you.
Thank you. Can we have Dr. B.N. Gupta, please? Are you there?
Dr. B.N. Gupta is not there, sir. BNR Subudhi is there, sir.
And Arvind is there?
Arvind Jaiswal is there, yes, sir.
It was really a fantastic program, sir. In the virtual platform, we had everything and we enjoyed everything. One thing, I am just eagerly waiting to have our physical conference in Odisha or in Calcutta.
In Odisha?
Yeah.
With
So
your with your Valentine.
Definitely, sir.
Sir, we have
So,
to make the Abhijit Das pocket slightly lighter, sir. It becomes heavier. Sir.
I am there, don't worry. BNR, कुछ बोलोगे, please?
Yeah, yes, respected President, my dear Dr. Pranav and Dr. Devasis, really it's a wonderful conference, and I enjoyed the executive meeting yesterday, a day before yesterday, and to all the programs today, you know, the pre-paper session and the quiz, and of course, above all, the keynote address by Dr. Asrif. It was a really wonderful program, and I never thought that this will come in this way. However, I wish, had it been a physical conference, would have enjoyed more, because in the last 2 years we are at home, not able to meet each other physically, and we hope this will end. And this is the last part of the virtual session. Let us go move forward, and please, I welcome you all to Puri. We have a darshan of Sri Jagannath.
Sir, we'll have it in
With the blessing of Jai Jagannath, it will be at your place.
And of
Is there any scope to tell something by the viewers?
Yes.
Why not?
Yes, why not?
Why not?
President is always optimistic.
I am amazed that Dr. Steve Arsnov attended the whole session and listened all the contest and everything. And his opinion was so much helpful to everybody of us. I am amazed how it was arranged. Firstly, secondly, we have instantly received the quiz result. But what about the free paper results?
Everything will come, once I take that. It will be announced now itself, after everybody's opinion is taken.
Professor Das, sir.
Professor Gunasagar
Yes.
Das, sir.
Yes. This was a wonderful midterm conference, and we enjoyed a lot. So I thanks all the organizers.
Is there anyone who wants to speak?
Sir, Dr. Swaraj is there. Dr. Nagendra is there, sir. Dr. Jai Gopal. Vibhuti ko baad mein, sir. Last mein, sir.
I would like to thanks.
Good evening, everybody.
Sir.
Yeah.
Okay, go first, Dr. Swaraj.
Okay. This was a wonderful conference, and all the things have been arranged by our president's guidance, secretary, and our scientific committee chair. And the quiz master, both of them, already I have given the official vote of thanks. Now this is only valedictory. Dr. Vibhuti and Dr. Shugoto, you have done a wonderful job actually. It was very much high standard. I hope in the annual conference we'll have much more beautiful time, fellowship and everything.
You have become a master of vote of thanks now.
Dr. Nagendra.
Sir, I am very much grateful to you all people, sir. President, sir, Secretary, sir, Chairman, Scientific Committee, and everybody for having such a beautiful and informative conference, MidCon. And I have gone through the excellent educational experience all throughout the conference. I hope, as Dr. Subudhi told, it should be last virtual meeting. I have been seeing Dr. Ghosh enjoying something else. So in Bihar we are.
अरे भाई नगेंद्र,
Lucky,
ये तो रामकृष्ण मिशन का मीटिंग नहीं है, डॉक्टर्स का मीटिंग है, दारू पी लेना होगा.
But for it is difficult to us for Bihar. This is only bad. So
हम लोग सर ये
jealous about it.
Gupta is not here. वो कहते हैं कि सब भूख
हम तो मिस
भूखे
करते
प्यासे लोग आ गए.
हम तो अरविंद को मिस करते हैं.
Sir, can
your guidance is always very, and you are like a elder brother to us, sir. So keep guiding us for the longer, as many as years in years to come, sir. Thank you, sir. Thank you, President, sir, and all the office bearer of the Eizoc.
can we have 2 words from, not only 2 words, but few lines from Dr. Vibhuti and Dr. Sugatopan? Dr. Vibhuti first, please.
सर हमारे यहाँ डॉक्टर्स नहीं मिलता सर, टीचर्स मिलता है सर. On a lighter note, 3 smiling faces, Abhijit Da, Devasis.
I forgot to congratulate Dr. Vibhuti and Sugato for the excellent quiz.
Abhijit Da, Devasis Da, and Pranav sir, please keep smiling. That enhances the whole energy level of this conference. And backed up by Amitabh Bachchan of Bihar Ophthalmological Society, Nagendra Prasad sir. This is wonderful joining you people and learning lot of tricks from you people. और बहुत जल्दी सर हम लोग अभिजीत सर की जो होस्ट की जो ये होती है
इनविटेशन
एंजॉय करने के लिए पहुंचेंगे हम लोग.
एकदम जय जगन्नाथ.
जय जगन्नाथ सर. जगन्नाथ जी बुलाएंगे तो आएंगे. जगन्नाथ जी के यहाँ जाना भी था बहुत दिन से. होप सो.
जय जगन्नाथ.
जय जगन्नाथ.
Dr. Sugato, 2 words from you also, sir. And after that, Dr. Jayagopal Agarwal.
Would we have one of the young persons to speak?
Yeah, Tanya is there. I just saw her, but
I'd like to thank Eizoc, Dr. Vijit Ghosh sir, Professor Dr. Pranab Ranjan sir, and Devashish Da, Dr. Devashish Das, for giving me this opportunity to participate in this conference. It was a beautiful conference, and also the free paper presentations were excellent. And thank you, Professor Vibhuti Sinha sir, for working with me, and we have become good friend. It was actually, it's a magic of Eizoc. Actually, we didn't even know him, and we are good friends. That's the good thing for me. And I am sure if we get scope again, we'll try to do our level best.
You are going to get it.
Okay.
And you have given.
तुमको तो दे दिया. We have given.
Dr. Tanya, if you are around, if you are listening to us, you can speak something. Dr. Tanya.
Is already been given, na?
But I think she's not there. Dr. Jayagopal Agarwal, please.
Yes, I'm here. Congratulations to all the team members, especially Abhijit sir and Pranav Ranjan and our Devashish. They have done a lot of great work for this MidCon, and I think it is a very successful. And the standard of free papers and the quiz are excellent. And first time I am attending this conference last 3 or 4 years, and gradually the free paper contents and its level has become risen too far. Now it is good for this Eizoc, and also the quiz. It is excellent, conducted by the Dr. Vibhuti and Dr. Saugatapal, and I congratulate them both. And I also have noted that the number of participants has gone very good. It is almost 40 around.
So it is more than that. There were viewers in the YouTube and as well as in the Facebook, which you are not taking into account. It's into 600 to 700 viewership on Facebook and YouTube.
Okay. That is a very good sign for the Eizoc.
That details we'll get tomorrow.
That is a very good sign for Eizoc. And our president, he will guide us in the future. And you and Devashish, They are doing a very hard work, and now for the after MidCon, with the annual conference, I think they will do much better presentation than this. And there's no doubt this midterm conference is excellent and very good. Thank you.
Yeah, we have a young one, sir. Dr. Abhijit, Dr. Tanya is here.
Okay.
Right?
Yes, sir.
Yeah,
Yes, sir.
yeah. Please go ahead.
Sir, that was an excellent, sir. Nice experience, sir, the first time. Sir, I'm really happy.
So you're going to permanently stay and permanently participate in Eizoc conferences and
Yes,
Eizoc
sir.
activity. Very good. Sir,
Yeah, may I request Dr. Parag Mukherjee to say a few words?
He's already spoken.
he has already.
And
yeah.
Dr. Ranjana Kumar.
Ranjana is well,
Ranjana
she's
is there,
muted. Acha, Dr. Ranjana, please.
No, she's not.
You can unmute if you can.
Ranjana is a total professional. जब तक काम है रहेगा.
Like, oh,
Sorry, Ranjana.
Sir, thank you, sir, so much for this opportunity. And this was a wonderful experience. And I think it was amazing. We learned so many things from the free paper presentation as well as the quiz. I tried to log in, but I could not. And I think I will not miss any further conferences that happen. I think it's been foolish for me to be missing some part of it earlier. So this has been an incredible experience, and this is a great team, and I don't think I've seen a better conference in recent times. It's been excellent. Sat through the entire conference, absolutely.
Thank you.
Abhijit, I just want to add one thing that we are not going to leave Ranjana. We are going to include her in some important post, so she can't leave it.
Okay, that's taken into account.
She's an active person.
I told her
Seriously, yeah.
in the beginning of the meeting. I told her.
So,
thank you,
Chairman, sir, should I speak or you speak?
No, you
Yes, sir,
speak.
please, sir, you speak, sir. I'll announce the awards whenever you ask me.
You are the main person.
Who, sir? Devashish is the main person, sir.
No,
I'm really amazed at the entire three hours that I have spent. I did not expect that it is going to be so good. I'll just use one word. It was really fantastic. And I would like to thank Dr. Steve, who stayed for such a long time. It was really fantastic. It was a maiden oration and a golden moment for Dr. Arvind Jaiswal, sir, our senior from Bihar. Dr. R.C. Meher free paper session, that also that was really excellent. Not only excellent in the sense of presentation, the number of participants in such a short course of time that we had to divide it into a preliminary round also. So the enthusiasm level was great. And because of this free paper session, I could get 10 new members added because all the new members almost applied for the free paper. So then I realized how much important this free paper is. And really, I'm thankful. On behalf of Eizoc, I thank you, sir, for giving us an opportunity of creating this space for us. Less said about the quiz. Sugato Paul and Vibhuti, both of you are fantastic. Sugato Paul, I know less, but Vibhuti, I know him for a pretty long time, almost 15 years, more than that. And I know his sincerity, his devotion, and his work ethics. He's a workaholic. He does it very well. And Ranjana also conducted the whole felicitation program with grace. And that is expected of her. And at the end, I would like to thank Chairman Scientific Committee for always smiling. He was the main force and who took the brunt of the entire thing which was taking place. And the amount of support that we got from Abhijit, the president, that was enormous. I mean, you do whatever you like within the constitutional framework. And he said, he's with me. That was given a green signal. That was the best part of it, without any argument, without anything, sir. So salute to President, sir, for giving me the free hand. And one more thing I would like to mention. I've become a fan of Biraj Goswami, sir. Two presidents that I've got. I'm really fell in love, I'll say, with Both the personalities, both were different personalities. Both of them were
अरे
fantastic.
क्या तुम love में पड़ जाओगे तो भाभी
And the third, love can be for anybody, sir. I love you, sir. And third, two people I admire, sir. Two people I'll admire, sir, for the free paper. One is Ashwini. In spite of all his handicaps, he was with me till 3 o'clock yesterday, sir, just learning how to share the presentation on the mobile. I said, if you are unable to do it, you come down. I'll have a man fixed and you will present, but you have to present. But he learned how to share the screen on the mobiles, and he spent around 3-4 hours time. I was busy with my patient with the Eizoc work. In spite of that, I said no, isko karna hai, because I cannot say no to him. And second is Gyan Bhaskar. In spite of his
Medical problem.
personal and health problems, health issues, he has done a fantastic work. I mean, these are two people who are really motivating us to do more and more. And
Never give up.
Never give
Never
up.
to give up.
Never to.
The
Yes.
basic idea is never give up.
Yeah. So, with these words, I hand over the screen to our dynamic chairman, scientific committee, Dr. Devashis.
I'll have a very short.
Puti wants to say something.
देवाशीष दा से पहले एक लाइन और बोल ले देवाशीष दा
हाँ बोल दो
देवाशीष दा इस बार का जो ब्रोशर्स आ रहा था दैट वाज ऑफ फ्लाइंग कलर्स इतने कंट्रास्ट का ब्रोशर्स मैंने देखा ही नहीं था ब्यूटीफुल ब्रोशर्स आई मेड अ रिमार्क आल्सो कि मैं खुद ब्रोशर्स बनाता हूं अपने जो सोसाइटी का काम करता हूं कई बार तो लेकिन आई हैव नॉट सीन दिस काइंड ऑफ ब्रोशर्स दीस आर ब्यूटीफुल ब्रोशर्स
The three-page brochure you meant?
Yeah, all one. All with contrast, one side border and everything. Beautiful.
That credit goes to Dr. Pranav Ranjan.
At least this art I have learned. And so in future also, anybody wants that I should create a poster for any scientific activity, I'm ready for that. It doesn't take much time.
अच्छा वो देवाशीष दा ने बता दिया बिहार ऑप्थेल्मिक सोसाइटी का कल का काम हो गया.
So with Devashis, more you have
please Devashis da आपको बोलना है.
More you have to speak about the results and all.
Yeah. Shall I start with the results?
Yeah.
Yeah.
So this is the free paper, Dr. R.C. Meher free paper competition results. First was Dr. Shantan Ghosh, followed by Dr. Sneha Batra, very close. All of them are so close, difference of 5 points, 3 points, 1 point. 320, Dr. Sneha Batra 315, Dr. Tania Roy Bhadra 313, Dr. Shikriti Jena 311, Dr. Reshmi Chandra 305, Dr. Gyan Bhaskar 291. Amazing. I congratulate all of them, but I also congratulate the first. Along with this, we have the quiz, first by Dr. Kaushik Tripathi, and Dr. Reshmi Chandra second, and Dr. Nitin Dhira was the third. So announcements. Yes, sir.
Devashis, can you share the first slide? I'll just capture it for record.
Oh, sure. I had already WhatsApped you, but I'll again share. I'll share it. So this one is
yeah. This is the free paper. Yeah, captured. And this is the second. I have captured the second one.
Dr. Meher free paper.
This I have captured. The second one, the quiz one. This just give me 1 second.
Yeah.
Yeah, captured. Yeah, done. And thank you, Devashis.
We will communicate with all the competitors tomorrow.
And
but I do congratulate all of them for joining us, and I do request them to join us again for our annual conferences.
And last but not the least, Dr. Abhijit Ghosh.
So I have two things to say. From my life, I have learned one thing as a teacher and everything, that you have wonderful juniors, and it is the duty of the seniors to give them their due respect and give them their way to work things, and that works wonderfully well. I'm telling you, all these people, whenever you people will be seniors also, please take care of your juniors like this. and let them go on working. If you give them the scope of the work and the freedom to work, they will want wonders. And your place will be much more stable, you know. If you won't let your juniors work, you will not be stable also. So this is the basic work of a senior person, number. And number two, if your intent is good and there's honesty, everything works, nothing happens.
Great.
So this is my impression about the whole thing. You have done wonderfully well. Let's not single out anyone. Everyone has done a wonderful job, and we will see that we go up day by day. It is not the question of why 1 year or others 1 year. It is a question of the Eizoc as a holistic approach. If we have to grow as a whole, we have to be of the same ideology to pick up our juniors and give them the proper guidance and the leadership to get in higher strength. This is our idea. Thank you very much.
I have one thought. In our next annual coming conference, I would ask Dr. Abhijit Ghosh to give us a philosophical talk.
A motivational talk.
Motivational talk.
In fact,
I will tell you, Debashish has been so close to me. His father, Santosh Da, is like my big brother. You know what he does to me? 15 years ago, I was sleeping in my house with my children and wife. He comes to my window, opens it, and says, "You're sleeping till 8 o'clock on. You have to have a morning walk with me." He gets me out of the bed. This is the person whose son he is. So we have a wonderful relationship like that. The main thing is Devashi's relationship bring in respect, you know. Unless you have respect for everyone, you can't develop. So this is the moon. So we'll have a philosophical world, don't worry.
Yes, sure.
Yes. So Bibhuti, you are having that quiz along with Sugato.
Sir, यहाँ सब leaders सब है sir. You have Vibhuti, we have Swaraj to take over from next onwards. Most probably. We have Devashish, we have Ranjana, we have so many people.
ये BNR है हमारा घोड़ा है. He's my horse.
DNR sir के लिए तो आपको सर कुछ करना होगा sir. You have to do something.
Sir. He is so good a worker.
Thank you, boss.
Sir, हम इनको बोले थे sir. I told him when I had a talk with him कि how do you manage so many webinars, sir? Every week he has a webinar, sir.
Thank you for the compliments, and I think we should look forward to make it our annual conference a wonderful conference.
Sir, उसको have it in Puri, sir, so that we can enjoy the beach, sir.
Hotel book कर दिया.
Yes, sir.
हमारा I am worried about you people in Bihar. You are so.
Why, sir?
You people so starved. तुम लोग क्या करोगे बाहर जाके? ये हमारा चिंता है.
वो वहाँ पता चलेगा sir. That you will get to know there only. We'll only have teachers, sir. All around.
We'll have a rehab center for you there. Rehab करना होगा.
एक वहाँ stall कर देना होगा, teachers stall, sir. That's it. That is going to teach everything, sir. Ophthalmology to everything.
Okay, then.
Right.
Okay, then good night, boys.
Good night.
Thank you so much.
Good night, everybody.
Good night. Good night,
Good night, sir.
Good night, everybody.
Oh, 1 second, sir. 1 second, sir. 1 second, sir. 1 second. Phenocaine का एक, sir, because they intort people, they have sponsored it, so we have to see that. And we have already many times we have seen, but still.
Okay.
Yeah.
Ramanji आगे.
Yeah. I just forgot. Yeah. Share your presentation. Yeah.
Yes, sir. Definitely. So again, I'll not say this is a webinar, but this is a midterm. The conference is supported by Intort Pharmaceuticals partially. Here, I will let you just show the Phenocaine Plus video.
Yeah.
Yes.
Just recently it has got the DCGI approval, and one more product which has been like the now we are promoting it. Thank you so much, Doctor, as well as all medical fraternity and ophthalmologists for making the entire in the current scenario also the India's fastest growing ophthalmic and ENT company, and it has the highest number of the product portfolio currently in its basket. Thank you so much, Doctor. Over to you, sir.
Thank you, Entod, and
Thank you, Ramanji. Thank you.
Ramanji, for supporting us for close to 1 year, more than that. Thank you so much for that.
Thank you, Ramanji.
And we look forward to your support this year also.
Sure.
Yes.
Definitely.
Thank you all.
Thank you. Thank you all. Good night.
Okay, sir. Good night.
Thank you all. Thank you. Good night.
Thank you. Thank you.
Good night, sir.
Good night. Good night.
Good night.
Next, Odisha.
Okay. Odisha, Puri.
Yeah,
Puri.
Yeah, Puri. Sir, we'll not talk about Odisha. We will only talk about Puri, sir.
Puri.
Yeah, yeah. You are welcome. All are welcome to Puri. Sri Jagannath.
Sri Jagannath. Yeah.
All are welcome.
Mr. Rahul, you can end the program.
Thank you.
Yes, sir. Yes, sir. Sure, sir.
Yeah.